Hello, everyone. I'd like to welcome you to Pacific Northwest University of Health Sciences. My name is Dr. Keith Minoski. I'm the director of the Northwest Interprofessional Health Collaborative, as well as a professor in family medicine here at PNW. And I serve on the NIHC along with Jen Gerheim. And we're very fortunate to be co-sponsoring this event this evening with the Yakima Neighborhood Health Systems Services. I know I get it wrong. I should have read it. Health Services. We've been partnering with them for quite some time, and we've been very fortunate to have common goals, and we're able to deliver opportunities for forums like this. So this is truly a special occasion. On behalf of the administration, the faculty, the staff, and the students at PNW, we'd like to welcome you to our campus. For those of you who have not been here before, in case you're interested in finding the restrooms, the easiest and closest restrooms are actually behind you on the first floor. So if you go up these steps, there's doors in the back that take you down to the first floor, which is a convenient way to exit the auditorium, or you can go out through the side doors here and circle around to the restrooms in the back. Probably near the end of the presentation this evening, there'll be an opportunity for question and answering, and we would request that you utilize the microphones that are located on your desk for that purpose. These microphones are wired into our recording system, and that will enable all questions to be heard on the recording. You just simply have to push the button when the green light lights up, the microphone is live, and then you can ask questions, and we would appreciate that. We would appreciate very much having questions asked, okay? So as I mentioned, this particular event is co-sponsored with Yakima Neighborhood Health Services. I got it right that time. And I'd like to introduce to you the president and CEO of Yakima Neighborhood Health Services, Rhonda Hoff.
Thanks, Keith. So I'm not going to read Dr. O'Connell's biography. You have that in your registration materials, and you can find a lot about him. But I'm going to tell you why we invited him today. So I've been a groupie of Dr. O'Connell's for a long time, more than 20 years when I first met him through the National Healthcare for the Homeless Council. At this year's meeting, our annual meeting was in Phoenix this spring, and he was speaking on a panel, and I thought, you know, how is it that this guy has done what he has done for 40 years? You know, this work that we all do is hard, and whether you're a case manager or a behavioral health specialist, a nurse, a physician, a nurse practitioner, this is hard work that we do. And, you know, in my opinion, especially in the Yakima Valley, you know, whether your patients are homeless or they are low income, they are hard to serve. They deal with a lot of issues. And I was listening to Dr. O'Connell talking about, you know, some of the work that he has done. As a physician and the president of the Boston Healthcare for the Homeless program, you know, he has become an unwavering advocate for the most vulnerable in our society. And many of the people that I know, and particularly the people that I work with, do the same. In our clinics, we have 9 clinics in the Valley, and I hear stories all the time about some of the hardships that our folks have gone through. Dr. O'Connell has always seen his patients not as statistics, they're not problems, but they're people that deserve respect and care. And that's one of our themes, is to be a welcoming organization to anyone that we serve. The essence of his work lies in perseverance, in empathy, in a steadfast commitment to helping others. And for people that look to find meaning in their own careers, Dr. O'Connell shows us that real change comes from deep, consistent effort. And his legacy teaches us that what we commit, we can also inspire others to do the same. We are all teachers and we are all learners. And so when I thought about asking him to come to Yakima, I thought about not only our providers, but the students that are coming into the world of healthcare. And so it was natural for me, because of our partnerships with PNWU, to ask Keith and Jen if they would be interested in partnering in this effort with us. So I'm really glad that so many of you have decided to come and you know, spend your valuable time in listening as well. So Dr. O'Connell's examples remind us that the work may be challenging, but the impact that we make on individuals and on society as a whole can last a lifetime. So you have his biography, and now please enjoy his stories. So Jim, thanks for coming to Yakima.
Thank you very much, Rhonda. I think I got it on, do I? Great. Thank you. Rhonda, thank you very much, by the way. Rhonda and I took the 11 o'clock plane from Seattle last night to Yakima, so it's totally a pleasure to be here, especially to be escape from the East Coast right now. We're finally getting rain. We haven't had any rain in months. A couple thoughts. One, first of all, thank you, just to all of you for coming and listening to this, because I'm actually usually going to other places to learn what you do. And I spent this morning with Rhonda and several of the people working for Neighborhood Health, learning what you're doing, particularly, and I was thinking, it's just a diverse thing in supporting people, not only when they're outside, but when they're in respite and when they're in housing. And those services that you provide are amazing. And I was joking before, half jokingly, that I would love to bring you all to Boston so you could teach us how to do that. But today, if it's okay, I'm going to just give you a little bit of just the history of what happened, because despite how nice it sounds, it took me about 10 years before I got from college to medical school. So I didn't ever have this in mind of what I would be doing. It was entirely an accident. So I wanted to show you some of at least go through with you some of the issues. And this picture here, which is what I try to start on most times, is a picture of the people, or at least the second generation of the people who put us together. And we started in 1985. There was a Robert Wood Johnson Foundation grant that was given to 19 cities across the country, including Seattle and Portland, Seattle and San Francisco and Los Angeles, where it was an attempt back in the 1980s to reach out and take care of homeless people before they came in to the emergency rooms, which is what we were seeing back then. And so I was going to become an oncologist. I was finishing my training in medicine back in Boston. All said I was interested in end-of-life care and palliative care. I wanted to learn how to do that, and I was going to do a fellowship. But I got called into my chief of medicine's office, and I don't know how many of you are going into medical school or something like that. But when your chief calls you in, you have to be careful. The questions are all rhetorical. Okay, you've got to say yes to whatever it is if you value your career. So he asked me if I would be the doctor on this new program, and if I would take a year out and go do that so we could get it started. And that my chief of medicine wanted our hospital, which was Mass General Hospital, to get involved in the community and really help out. So I was kind of the guinea pig, and I got sent out to do it. I tried every which way I could to say no, but there was just no way around it. So you got to check this. So I finished my residency full of myself, and any of you who are go through this, you'll experience this. When you're a student, your ego can fit into about a ping pong ball, right? And then by the time you're finished, like my last job was running the intensive care unit at Mass General. I was a senior resident in charge, and I could not have stuffed my ego into this room. You just think you're good. And so I finished that, in June. And July 1st, I went down to the shelter, which was 6 blocks down the street. And I figured, I'm the first doctor they've ever had. It's a shelter. How hard can it be compared to the ICU? And I think the story I'm going to tell you today is just about how immensely harder it is to do that than it was to do the ICU. The first thing I didn't know was that I was going into the community with all these ideas of what we're going to do. I had all my friends ready to volunteer. I had, I had it all pegged out. But I did not know that this group of people had been forced to sit with the mayor who had gotten the grant and tell the mayor how they wanted to be served. Okay, so it was my first real learning what the community is all about. And I didn't really learn it, I got told it. And they insisted on a whole bunch of interesting things, and I'll show you some of it. But they, all of these people were homeless or had experienced homelessness. And let me see if I can learn how to do this. And here's what they came up with. They sat down, and after 8 months at City Hall working with the mayor and lots of groups, they came up with these 3 things. And I share these with you only because it sets a theme, okay? And I promise not to show you many more slides that have words in them. But look at this. They wanted continuity of care. And they were, I'll never forget this as they explained it to us, their lives were full of fragmentation and loss. Nothing was consistent. And the last thing they wanted in their healthcare system was more fragmentation and stuff. So they wanted a continuity, the same way most of us would want, where somebody knows you and then they march through life with you. And they wanted that continuity, if you notice that, from street and shelter all the way through to hospital, and we could add respite, as you'll see in the last thing. So they wanted it to be a continuum across the healthcare system as well. So it was a continuum across time and across the system. And then the second thing they did, which is a theme I hope all of you, now this is second nature to you, but it was not to us back then. They made us work in teams, okay? And I'd come out of the hospital being trained where you're really trained to be singular and not work on your own independently and really get things done. And here they didn't want anything like that. They wanted us to work in teams. So I have, for example, never had my own panel of patients in all these 40 years. I've always worked on a team where we share in the care of our folks. And it's usually a nurse practitioner, a physician assistant, a recovery coach, a psychiatrist, and nurses and caseworkers or social workers. And we all share equally in the care of every person we take care of. And I thought that was kind of brilliant, like here it is, multidisciplinary team, and it was not that at all. And this is where my first humility lesson came up. They hated people like me. Here I was going to do a year of taking care of people, and then I was going to go do my fellowship. And what they were saying is, we don't want you to come and spend a year with us, and we're going to open up and talk to you and tell you what's going on. And then at the end of that year, you're just going to pack up and go do your career somewhere else. And they hated that. And here I was thinking, I'm giving them a year of my life. This is, I was doing good work. And so it was like smack in the face. And I was not ready for that at all. The other thing that was really interesting, I'll show you, is that they also didn't trust us doctors in the hospitals at all. And they went to a big law firm in Boston called Hale & Dorr. It's the biggest, law firm. And they got them to draw up a thing which had all these things that the mayor had to sign on to in order to get the grant. And not the least of which was, this is 1984, okay, was that we had to be all about social justice and not about charity. So this was an early, healthcare should be our right, not something that you give to me as charity. I wasn't ready for that. I was in a world where, I was so buried in the hospital for 4 years in medical school and 3 years in residency that I wasn't thinking social justice world at all. But I was thinking charity. I thought we should all be giving back, which to this day I do believe, by the way. This is all from the eyes of the people being served. And so they wouldn't let us use any volunteers. So the whole system I had set up was null and void. And I couldn't believe it, but they said, look, to them, and this is the eyes of the people you're serving, volunteers smacked of charity. It's not who of us goes to a volunteer primary care doc or nurse or something like that. They wanted permanence. They wanted consistency. And then the other thing they wouldn't do is let us use students. And I had just come out of a world where students are integral to everything we did. And we thought the best of care that was also involved getting students involved. But they didn't see that. Their only experience of students, and that you have to forgive them on this, or I had to because I was furious, is their only experience is students who had come down to the shelter, done physical exams on people, learned how to feel hearts and listen to lungs and all that. And then none of those people ever came back and did their careers, taking care of them. They just all went off and did something else. So they didn't want to be guinea pigs anymore. They said, we don't want that. Even though I had all students ready to come. We had all knocked. We also couldn't do any research. By the way, all this lasted for about 5 years, and then it all went away. Once we set up a consistent system of care, where it was an infrastructure that was consistent, we could start to do all that. But not in the beginning, and not for 5 years. And the research baffled me because I came out of a sort of a research-oriented, education-oriented academic medical center. And you know what they did? And I toss this out. We can talk about this later and be interested in how you feel. But there had been some research done in Boston shelters in 1983 and 84 by a really good Harvard psychiatrist who had gone into the family shelters with the permission of all the shelters and done a big study on homeless families and mothers, particularly, but then the kids. And the study, which, she had access to everybody with, the study came out and showed something that I thought was a clarion call to all of us, that these families had been through unspeakable trauma, and that many of the moms were really troubled and traumatized with PTSD and everything else you can say. There was lots of depression. But in particular, he said that about half the kids were in need of immediate psychiatric care. And I thought that was profound. But if you're an advocate, right, and this is what I had to learn to jump across, the advocates at that time were saying to the administration, the administration in the 1980s, which was President Reagan, that homelessness is a problem of a lack of housing. we got out of the business of putting, in 1982 or something, it was a $90 billion a year in our dollars investment in very low income housing that HUD was doing. It went down in a year to 20 billion, and in those dollars has never gone up since then. So we've lost a huge chunk of money that was invested in low income housing, very low income housing in particular. And what the advocates were saying, if you hadn't done that, we wouldn't have housing. And here's a study now saying that maybe it's not about housing, it's about people who are all messed up. So it was a blame the victim view that the advocates saw here, and they said that is not anything we want to have. So we were not allowed to do research. They said it's getting in the way of our advocacy. And that tension, if you think about it, will always exist. There's always this kind of, you've got to find how to advocate well, but if some research comes up saying what you're advocating for maybe not be right, it's a real tension. So you want to work together and not apart. So we couldn't do any research. And then we couldn't do mental health things because back then, and I don't know how many of you may remember this, probably no one except us, is we had deinstitutionalized the very mentally ill folks in our society. We went from 700,000 inpatient psychiatric beds down to less than 200,000 across the country. And the thought was many of those people now would do well with our new medications, and particularly with community-based services where they could go into the community, live near their homes or in their homes with a lot of support. And everybody, it was part of the 60s. We all thought that was, civil liberties, civil rights, let's get people out of these awful institutions. But then what happened is we never invested the money in the community services. We just emptied the hospitals. And what happened is, eventually, there's a little twist in this because of the way SSI worked, is that most of those people ended up in flop houses and shelters in our country. And that's what fueled part of what fueled the homelessness crisis. So the shelters were angry at the Department of Mental Health, certainly in Massachusetts, for not providing those services. And they didn't want some program like ours getting them off the hook. So we were not allowed to do that. So all of that was how we started. So when I give you the early parts of our program, just put that in your frame of reference. It's kind of wild. And just for, I throw this slide up there so I have to always remember that, like politics, all care of homeless people, and often strategies are local. It's what you can do in your local context. Okay, for example, in Massachusetts, we don't have counties. We only have cities or towns and the state. So we don't go through a county system. If you live in LA, it's completely crazy because you've got the city, the county, the state. It's a lot different what you have to do. And there are possibilities in some places depending on what your Medicaid system looks like, what your hospital system looks like. So I've learned by going around that almost every, there were 19 healthcare for the homeless programs that started in 1985, and they all looked radically different. So it wasn't as if we've ever been able to. And now we have, how many? We must have 330 healthcare for the homeless programs around the country. And they all look a little different depending on their local politics and healthcare structure. So this is Boston, and I would just show you that. So we have we're a small city pretending we're big, okay? We have about 600,000 people is the population of Boston, and that map is about 2 miles by 2 miles. So it's a very small geographic city, and if you look at that, the yellow triangles are where the adult shelters are in Boston, okay? And you can see they're sort of clustered around an area which is our downtown. There's also family shelters, which you see are the red dots, and they're in the neighborhoods. They're spread out all over the neighborhoods. So we already had what I had to learn was there's a radical difference between adult homelessness and family homelessness. I'm going to spend most of my time today talking about adult, but if we want to in the questions, I can tell you all about the family part of our program. But I don't know if there's a pointer here. Is this a pointer? Oh, I did something wrong here. Oh yeah, this is this thing. Oh my God. That's what you showed me where it is. So there's something here. I don't know how to do it. Here it is. How do I do it? So right here, see this thing called Long Island? That's our Long Island. That's not the Long Island that you would see but that's the city of Boston. What happened is, and I just wanted to show you one local color thing, is we had one big shelter of 800 people called Pine Street Inn, which I'll show you in a moment. And right about this time when homelessness was burgeoning in 1982, 83, 84, the Pine Street said to the mayor, we've got 800 people, we can't handle anymore, you have to come up with a shelter. And he tried to find a shelter, and couldn't get a neighborhood that would accept one, right? Surprise, surprise. So it turns out Boston had the oldest chronic care hospital in the country was on that island. It's an island owned by the city of Boston, and it had pretty much, many, many buildings there were empty. So the mayor realized, I don't have a community out there that I have to convince anybody to, and we can just bus people from what is one of the hospitals downtown, Boston Medical Center, was Boston City Hospital, the 10 miles out there every night and then bring them back in the morning. So when I first started, I remember thinking, what city would put homeless people on a bus and get them out of sight, gone, and then bring them back in the morning? But that's how the city responded. And it turned out, this is what I'm sorry, I did something wrong here. I got to go back. I'm sorry, threw in a couple of slides. One of the things we were, I apologize for this, one of the things we were made to do was to be part of the hospital. So we had this strange thing, we were unlike any of the other programs. But the homeless people that put us together said that, look, when we're sick in a city like Boston, we end up in one of these big hospitals. And that's when they felt most frightened and most stigmatized, is what they would say. So they said, look, we want to, and back in the 1980s, usually your doctor, your primary care doctor, your team took care of you when you were in the hospital and then followed when you were outside. So we had to become part of each of the hospitals and take care of people when they went in there. And that was a requirement from that. So our hospital, this is Boston City Hospital, which traditionally took care of the poor, and Boston is a great hospital. It's now called Boston Medical Center. It's changed. We have a clinic there every day, and we have since 1985. And the other hospital is Mass General, which was a hospital I came from, and that they wanted one of the private hospitals as well as one of the city hospitals to be involved. So we have clinics there every day. And that was so that we could sort of have some sort of continuity through the healthcare system, okay? And it's also unique to Boston. Remember, we have 12 academic teaching hospitals in where that map is. So it's a very crazy world. Now, this is the island. This is a shelter that the mayor started on the island, on Long Island. And when I had to go out there, and when I first started, so it was 3 nights a week at Pine Street, I'll show you in a minute, and 2 nights a week I spent out here. And it's a 10-mile drive. And when I got there, I was so angry with the city I thought of this like Molokai, where we sent lepers or something. It was not really, but then when I got out there, I realized this place is beautiful. If you look at downtown, you can look, it's on the water looking at downtown Boston, and it's a lot of fresh air, it's wide open, and many homeless people loved going out there. So I had to accept that first it was a choice, you didn't have to go out, and if you chose to go out there, people loved it. And this is the view from the back door, so it was like stunning to me, and I went, maybe this is not so bad. In fact, it's unbelievably valuable real estate, which is still not doing anything. You can see Boston in the distance. That's what it looks like. If you took a photo from the plane a few days ago, that's what it looks like, okay? It's now closed down, okay? We had 700 people in various shelters. There was dual diagnosis detox. We had lots of different programs, housing programs, post-release programs, and they were all out there because we didn't need a community process to get them done. If you had the money and a good idea, you could get it done. But if you notice, up at the top, you have to get there by a bridge, and this bridge is now broken, okay? And then I can tell you exactly, on October 8th of 2014, the bridge was deemed impassable, and there was 700 people in all these programs. We had our program had 7 different clinics out there going most days, and the bridge was impassable, and we had 3 hours to evacuate the island. And it turns out the bridge is not fixable, so all those people were brought downtown, and it precipitated what for us was a really terrific or tense crisis in Boston, which we could talk about in a minute. But I wanted to show you that because it falls off the picture now because we don't have anything out there. There was also, by the way, out there a farm tended by homeless people that produced all the greenery for the shelter's kitchen. It was really quite extraordinary. But this is Pine Street, the shelter I went to that first night leaving the hospital. It's 800 people there. It is the oldest and the largest shelter in New England. And I remember I didn't know anything about it. It's called Pine Street Inn. I didn't realize it was a shelter. I thought it was an inn, and when I got there, I was kind of surprised. But I got there and I walked in, expecting to be greeted. It's my first job as a doctor. I'm really full of myself. And I walked in there and it was sheer chaos. There are people all over the place, lots of stuff going on. And I started to realize that I used to have control in the ICU and I have 0 control now. I was totally helpless. And I walked in, and there was a nurses' clinic there. And I don't know how many of you are nurses here, but what I'm going to tell you today is all that I learned from nurses. So wherever you are, thank you. And the nurses had been going down to the clinic, going down and running a clinic there for about 10 years before I showed up. And they felt they really knew what to do. And so when I walked in, they read me the Riot Act. I have an older sister, by the way, who's a nurse, so I know the stern look of nurses, okay? And they sat me down, and they were on the cover of the American Journal of Nurses that same summer that I started. So here I am thinking I'm coming to help out, and they're the premier clinic in the country. They were the only independent nurses clinic in the country. And what you see there is one of the significant things. They engaged people by, one, being there all the time, and two, by inviting people in and asking them can we soak your feet? Can we do something to help you? They didn't invite you in to say, are you having chest pain or all that stuff. They really were trying to engage you. And so the nurses set me aside, and I spent my first 2 months, soaking feet. That was my job. They took away my stethoscope, they took away all my stuff, and here I am, I keep thinking, I'm supposed to be in a fellowship learning oncology, and I'm soaking feet. And this was one man that, is the oldest picture I have, actually, who, the reason we took the picture originally was he was a character, but his feet were so swollen he needed 2 buckets. I don't know if you noticed on the other slide there was only 1 bucket where you put your feet in. This man had terribly, swollen legs from chronic venous stasis, had lots of breakdown, often had infections. It was either cellulitis. We used to be afraid that it might get worse. But he had come to the emergency room. I had seen him, 20, 30 times when I was a resident. And we had written in his chart that he had terrible paranoid schizophrenia, and he was completely resistant to treatment, because he would never do anything we say and would, just come in and sit down, and police would have brought him in. He'd look at us crazy and then leave, not do anything. So Barbara, the nurse who was teaching me everything, her name was Barbara McGinnis, made me soak his feet. And I remember it was about a month after I was soaking his feet. He's looking at me all that time. He's got this kind of wry look on his face, never says anything. Till one night, he says to me, he said, "Hey, I thought you were supposed to be a doctor." And I didn't know how to interpret that, but he was the first person in the clinic that acknowledged I was a doctor after a month. So I was like lit up, and I said, "Yeah, I am." And then he goes, "What the hell are you doing soaking feet?" And I didn't know what to say to him, I remember that, except to say, "I have no idea, but I do whatever those nurses tell me to do." And he laughed at that. He actually laughed. It was the first time I ever saw him show an expression. And he laughed because the nurses always told him what to do, and he would do it. So he and I bonded over that. And no kidding, a week after that, he asked me, he said one day, he said, "Doc, I can't sleep. Can you help me out?" Right? And he was asking me to give him some medicine to help him to sleep. And I was stunned, And then within about a month after that, he was taking all these medicines that we had spent 25 years at Mass General trying to get him to do, and he never did. So there was a brilliance in what the nurses were doing that taught us how, which you all know all too well, it's all about engaging people. How do you earn their trust? If you don't take time to do that, we'll be calling them treatment resistant, when in fact they're only resistant to our kind of treatment, not to treatment. So that was a huge lesson for me in patience. And I remember finally, the nurses finally let me go, and I could see people. And this was a man who, his name was Amerigo. And he used to, remember, this is a huge, Pine Street's crazy. And his laugh, what you could hear, no matter how crazy it was, you could hear him laughing. It was just that kind of unique laugh. And everybody loved him. He was just a real magical kind of guy. And one night he came into me and he goes, "Doc, you got to do something." And I said, "Amerigo, what's going on? What can I do?" And he held up his bottle of vodka and he said, "I can't swallow this damn stuff." And that's exactly, I didn't know whether to laugh or cry, because that's a terrible, if you can't swallow liquid, that's bad. But because he was pointing out his vodka, it felt a little weird. But it turns out he hadn't been able to swallow food for weeks, if not months. And he was okay as long as he could still get his vodka down. He was okay. And then when it wouldn't go down, then it was time to go see the doctor. And I learned that's a thing you must all do. People are kind of functional. They are so resilient. They will do anything they can, and it's only when something breaks that they will come in to see you. So the thought of doing preventive medicine or something that you could do to prevent stuff is a challenge. Anyway, he came in, and it turns out, he had a huge esophageal cancer, so he couldn't swallow anything. It was way beyond anything we could do, past surgery, past any chemotherapy. So he put in a feeding tube. And I said, Amerigo, I'm going to get you, I gave him the talk. You probably only got 4 weeks, maybe 5 weeks to live, but let's find you a place to be where you're safe, you can die with dignity and all of this. And I spent a weekend trying to get him trying to get him into a nursing home, which was near the place where he had grown up in Boston. And I did that. This is before computers, you guys, so it was a lot of paperwork, okay? And I was so proud of myself. I came in at Monday. I got him, we brought him over to the nursing home, got him all settled in. And it was really nice. It overlooked the water in the place where he had grown up. And I felt really proud of myself. I finally, this is it. I've finally done something good. And I came back to the shelter. I was there 3 nights a week. I came back 2 nights later, and I'm walking in the alleyway, and I could hear his laugh, that unique laugh. And there he was with all around a whole bunch of people, and he's holding court, laughing, having a great time. And I walked over to see him, and he's got his feeding tube here, and he's just pouring the vodka into his feeding tube. And I was like ready to kill him, like, what are you doing, Amerigo? And then he read me the riot act. He said, look, I appreciate all you're doing, Doc. He said, but I've only got a few weeks to live. And you sent me to this nursing home where I didn't know anybody. Everybody was either looking out the window or watching TV, but I didn't know anybody. He said, so I want to be back here with my friends. I want to die among the people I care about. And I had never, ever thought to ask him what he wanted. I had just decided, here's what he needs. And it was this huge lesson for me, which I hope have never made that mistake again. Hope you don't. That it's what somebody wants, and how can you help do that, even when it's not maybe what you think is the best thing for him. So anyway, this is Sheila, one of the nurses there. And he was the first person we actually did end-of-life care at the shelter for, and he lived about a month after that time, getting tube feedings, just the way you would have expected. But it was actually kind of gratifying because he died with all the people he cared about around him, So now, I have some humility slides here. That was one of them. This is my second one. So this is a man that the staff in the shelter brought him in one night, and this is not the nurses, this is the staff. They said, Doc, we've known this guy a long time. He just doesn't look right? And I laugh now because I used to dismiss that a little bit, but now when somebody in the shelter out there says somebody doesn't look right, you have to turn the volume up way high because that's chaos, and above chaos, they're seeing something. But anyway, he came in. His name is Jack. He was really angry that the staff had brought him in. He didn't want to be there. He let me take his vital signs. They were completely normal. He took off his shirt, and this is scabies. You can see a lot of scabies. And he's also got a basal cell in front of his ear. He's got, if you're interested in the anatomical finding, he's got pectus excavatum. You can see that. And he openly admits he's drinking and smoking too much, but I don't want to talk about that now. I'm fine. Okay? And he had a chronic cough, but that was it. And I listened to his lungs, and they were clear. Okay? Now, don't forget, this is not exactly the quietest place you can be, but it was clear. Air was moving everywhere. And so and he didn't have a fever, and he said, I've been like this, nothing's happened, let me go. And he really wanted to be out, so I let him go and told the staff, I can't find anything acutely wrong with him, so if you think something really is bad, bring him back. I'll be back 2 nights from now, bring him back. And we have an old x-ray machine at Pine Street. This is 1985, and this was his x-ray. It's a man I had examined and sent out as fine 2 nights before, okay? So always be careful. This is tuberculosis, cavitary tuberculosis, like you would see usually in a third world country where you have no health care. And this man, you can even see if you're into this, is a right apical pneumothorax, and he's huge loss of volume. But if you put your stethoscope on that chest and listen, air is coming everywhere. You can hear air coming in and out. And since he's had such a chronic cough, you don't really hear much going on otherwise in his lungs. But he became the first case of pulmonary tuberculosis, active pulmonary tuberculosis, of 60 cases in the shelter within the next sort of months to a year. And it was mostly INH and strep resistant, which are the 2 most common medications to treat TB with. So here I am in the shelter, thinking this is going to be easy, right? And here's a guy with tuberculosis, soon to be 60. 40% of everybody in the shelter had their PPDs can go from negative to positive, so the reservoir was huge, and it became something way beyond anything we could do without being a village, without getting everybody together to take care of it. And it became a big deal it was sort of the first MDR TB, if you guys read a lot about MDR TB, I could talk to you about that a lot. It required 4 medications every day for 18 months to take care of. And I was like, are you kidding me? There is no way we're going to be able to do that. But then the outreach, the folks at Pine Street and everybody that we knew said, look, you're looking at it all wrong. While it seems like chaos, most people have a relatively ritualized daily pattern. He said, and if you just put it into one-on-one, you'll start to realize this person's going to be there every afternoon at 2 and then come somewhere. So we had to finally get, with a lot of help, start to do that. This is Barbara McGinnis. I have to always show that. She's the nurse that made me soak feet, and she's on the left. And Barbara was actually the state public health TB nurse assigned to Pine Street. And this is her office. You can see, for those of you who have never been around for that, before digitalization, we had these huge x-rays we had to carry around. It was really difficult. And Yoshiko is a nurse practitioner who was my partner, along with a caseworker named Mark, for the first 15 years I did this job, and she was just remarkable. But anyway, this was the command center where they kept tabs of whose PPD has turned positive, who had TB, and how we'd go find them. And what we had to do was basically go find everybody. So when I think of the street medicine part of our program, it goes back to 1985 when we had a TB outbreak, and anyone who got TB in the shelter never came back. They were outside, because they thought that's where they got sick. So we had to go find them. And this was a picture we took with Mark on the right is the caseworker that worked, Yoshiko and myself, and Ursula is a TB outreach nurse. And we would get on our bikes, go find people each day, and divide it up so we all could get to the different people. And here's where I learned something that was really kind of, I was a bartender for a long time, okay, so and another time, if we want to talk, I can tell you that most of the skills I'm telling you about today, I learned bartending, not in medical school. But I had a friend who was a bartender just at a bar down the street from where Pine Street Inn is, right? And there were 7 of by the way, the 60 cases of TB were all men, they were all drinkers, and none of them were immunocompromised. So this is just before the AIDS epidemic time. And but there's 7 of the men on our list would go and get a beer or more at this bar before they came into the shelter for the night. Well, the shelter, you come in drunk to the shelter, you can't, we have what we call wet shelters, so you can be drunk and you can't use in the shelter, but they won't kick you out because you're inebriated. So what we did is gave him the medicine, and before he would pour the beer each day, he would make the people take their medicines. And so he treated, or that bar treated 7 of those people through all 18 months. And there was a coffee clutch in South Boston where 4 of the men used to go for coffee every morning, and we got that guy to, before he'd pour their coffee, they had to take their medications. And I started to realize this is like really a village. This is in the middle of the heaviest duty medical mecca ever. We're using bartenders and barbers to help us do TB treatment. I could tell you much more about that, but everybody got treated. It was really interesting. Nobody died. There was one person who escaped, but he escaped, it turns out, because he ended up in prison. But it was a lesson for me that we were useless when we're working alone, but when you work in a team, when it was a state and the city and the nurses and the doctors and outreach workers, you could do a lot. You could do a lot of things that I would have once said was impossible. So back to what they originally asked for, and the third thing, if you look at it, there was, we had to set up, this is 1984 they did this, right? And what we had to do was set up a respite program, respite care. And now, I'm looking at Rhonda because we didn't know what, nobody had ever said the word respite care. We didn't know what it meant, but they had a very precise meaning. Homeless people did. They said, when we get kicked out of the hospital and we're really sick, we have no home to go to. So we need a place where we can go, where we can stay 24 hours and have nurses and doctors take care of us. And that was a simple early version of what respite was. And it was medically oriented because it was really sort of what in the world, since we couldn't do mental health care, it was medical stuff, right? And this is the earliest picture I have of our respite program, which opened in September of 1985. Why would I remember that? Because we spent so much time getting it going. But Governor Dukakis gave us 25 beds in one of the shelters, and we opened up. We didn't know what we were doing, but we just would get people coming from the hospital. Sometimes they were coming from the streets, but mostly from the hospital. And you can see Betty Sneed is on the right. She's our respite aide who became really magic in all this. And we would have, a full-time team, a doctor, nurse practitioner, and social worker, in addition to the nurses there. And people were pretty sick. But back in 1985, for those of you who were not alive then, much to my chagrin, if you were in the hospital, if you were at Mass General, our hospital, it had a CABG, open heart surgery, coronary bypass surgery. Do you know what the average length of stay was at a big hospital? Anybody got a guess? No, okay. It was like 5 weeks. 5 weeks, okay. Now do you know what it is now? It's about 3.2 days on average, okay. And if you had cancer and we needed to treat you with chemotherapy and radiation, we would admit you to the hospital, give you your infusion, and keep you there until you were healthy enough to go home. Okay, and if you had most surgery, like hernias, that was 6 days or 7 days in the hospital. Gallbladder was usually 10 days in the hospital. And so when we opened that up, most people had been in the hospital for a long time and came to us. But now, as we've all learned, those of us who are involved in respite care, and there are now, I hope Rhonda will mention this when we get into questions, but there's now 75 or so respite programs around the country, including a couple of amazing ones right here, where hospitals now will kick you out after a day or two, and most of the stuff I told you about, hernias, gallbladders, knees, all that stuff is done as outpatient now. So what does a homeless person do? If if somebody has to bring you to your surgery and pick you up after your anesthesia, they don't have anyone do that. And who does the pre and post-operative care? So respite programs have sort of begun to fill a gap, a changing gap from what we originally were. And so in addition to the IV antibiotics that we have to do and all the other stuff, it was really learning how to deal with more and more acute care because the system stopped caring for homeless people after they were very acute. I just threw this in. This was an example of one of our first patients. He came from the hospital and he had this hernia on. He had been hit by a bicycle and broken his neck. And they put on this hernia. What am I trying to say? Halo. And it needed care, but they didn't need to stay in the hospital, so they sent him to our respite program. And you had to make sure those screws and nails didn't get infected. And I remember I saw the discharge summary, and the summary said, 45-year-old man hit by the car, and actually said in the discharge summary, with impressive damage to the car. So you get a feeling of what the priorities were in there, right? But then about 3 weeks after we opened up, so this would be early October, mid-October of 1985, this man came in with kidney failure. He's on ambulatory peritoneal dialysis, so his hospital didn't need to keep him anymore because you could do that in an ambulatory fashion. But you can imagine what it's like to do that if you're living on the streets or in a shelter. So we brought him in, but his kidneys had failed because he was the first person we knew in Boston who was homeless to be diagnosed with AIDS. And this is 1985. So the AIDS epidemic was slightly behind. As an intern in 1982, we saw our first case at the hospital, and we started to see more and more cases, but hadn't hit the drug-using community as much by then. So anyway, he came in, and then we started to realize the world now changed. We had this one TB epidemic going on, and now AIDS, this first person, within about a month, there were like 20 people, and within 2 months, there were hundreds of people. So it just was horrifying. And for those of you who don't know, we had no way to even diagnose it up until late 1985. We didn't know what was causing it. And we had to wait till somebody showed up sick with an infection that they shouldn't get if they've got a normal immune system to start to say, well, they must have AIDS. And everybody died. We had no treatment. So as far as we could tell, everybody died after about a year or 2 or 3 after getting all these opportunistic infections as their white cell count went down. Anyway, I just remembered as being the time I thought I needed to find another profession because it was just horrifying to be around that. Anyway, then just a little introduction here because we were talking about this with the Hope Loss stuff. And then in 1996, the protease inhibitors came along. Okay, so for me, it was like for 11 years or maybe for 14 years from the time I was training, everybody essentially died. We didn't know. There are a few people, obviously, who are called long-term non-progressives, but we didn't know who they were until much later. But the protease inhibitors came along and took people who were on their deathbeds and made them well. And all of a sudden, AIDS was transformed into a death sentence, into something that could be really a chronic illness that you could live with and maybe probably die of something else. And it was radical. It's probably the most radical thing in my career that has changed. We now have an HIV team in our program that follows all the people who have HIV in our system, and it's now up to about 600 people. But they've learned by chasing them, much as you guys do here, by chasing people around. We have the nurses team is called the NAG team. They nag people. But they can get people to take their medicines, and then they have viral load suppression rates equal to any clinic in the country. And so you can do it, but you have to go back to the same way we did TB and the same way you did that. So I think now, like, maybe there are some, whatever you say, there are good things going on all over the country and taking care of people who once would have died. So our respite program now has moved into went from that shelter to an old nursing home, and now we have it in this is a shameless ad here, but we moved into an old building right across from the emergency room at Boston City Hospital, which is the largest trauma center in New England. And so we have 104 beds now in this building, along with a big clinic and a bunch of other stuff going on. And it's got like a blessing to us. We moved in 2008. And it turns out, just as a little aside, it was the old city morgue. So when you think of where do homeless programs end up, they end up in kind of funky places, including the old morgues. But it's beautiful, and we had to restore it to as it was in 1930. And there are two sphinxes guarding the stairways down to the morgue. And you can't tell, but there's a winged hourglass there. So when you walk down the stairs, there's an hourglass and a gold wing that's letting you know your time is limited. Remember that. So it keeps us on our toes. But it's been great. So we could sort of design it the way we wanted, and that's one of the beds in our respite program. The only reason I show you this is because we were just doing sort of standard things. We thought we were creative and all that, but the only brilliant thing we really did was have individual TVs. Can you see that one on the link? That only works with headphones. So everybody has their own TV right at their bedside and can do, it turns out with one Netflix subscription, you can do all 104. So everybody, it's quiet. It's quiet. Everybody loves it because you don't have to go to we used to have, in our old building, we had a TV room, and then, everybody had their own room. And what we found is the worst fights we ever had were when soccer was on at the same time the Celtics were on. And, one group wanted one and the other group wanted something else, and we only had one big TV. So all that's gone now. So if you're going to do something, I recommend, it's not as expensive as we used to think, although we now can do much, those are big TVs. Now you can do a much smaller version of that. But we get to do things, and I'm sorry, this is the only gross picture I think I have, but I wanted to point out, so frostbite, which is a passion of mine, we see a lot. And we used to keep people in the hospital. You don't keep people in the hospital with frostbite anymore. It's a sort of an outpatient, you have to watch carefully, but you don't get admitted to the hospital. This is a man who we grew to love, and this is one of our nurses at McInnes House. But this man was walking outside. He was limping. It was what we called the polar vortex many years ago in Boston. It was freezing cold. It never went above 20 degrees for over almost a month and a half. And he was outside walking on it. We finally coaxed him in. It took a long time. I could show you some of the pictures that I spare you on that. But when he came in and we took off his shoes to go upstairs, his feet were completely frostbitten and black. But he let us keep him. This is one of our nurses doing the daily changes. He ended up, I can tell you a long story, but it's a horrifying thing to happen because it's completely avoidable. And he's going to lose both of his feet now. And his life is walking, his life is walking. So if you internalize that and you start to realize what that means to this man, it's just horrifying. But then the nice thing of respite programs is that you can have sick people there and then invite the specialist to come to you. And we find that with a very sick population, like we often have, or at least the segment of our population is very sick, specialty care becomes really critical. And so this is a dermatologist who's the head of dermatology at Mass General, and he comes with the residents once a month, actually now once a week, to see anyone we can bring in who has a derm problem. Turns out most of our staff try to sneak in because we have derm problems and we can never get in to see the dermatologist. But you can see he's just doing teaching rounds with this man who'd been in the hospital been in and out of emergency rooms for a long time for what they thought was cellulitis of his legs, and it turns out it's not cellulitis. It turns out to be a dermatitis of some kind. So having the specialty care there has been fabulous. Ernesto has just retired. He did this for 35 years and is now just retiring. But then the other thing, there's a million things, the IV antibiotics and the, managing diabetes, things you can imagine that's really hard to do outside or in the shelters. You can do with 24-hour nursing and doctor care, and we have psychiatric care now. By the way, I should have said that after those 5 years, we now have full, we have behavioral mental health care now in a big way. But we learned the value of it by not having it for 5 years. And then you realize how important, if any of you that are in that field, you are so critical to our lives. But end-of-life care became a real challenge ever since that very first man who died. And we learned that while hospice is great For many homeless people, it just didn't mesh with how they wanted to be dying. Not for any, bad reasons, but they're just different, culturally very different. So we've learned that for many people, we have to just acknowledge that they will do their end-of-life care at our respite program. And this is two people that we grew to love. Tommy, who's in the left there, is 82 years old at the time. He's dying of a neurological cancer. And he has just a little bit of time to live, but he's a sweetheart of a man. And his roommate is a guy named Byron, who's 37, half his age, and has lung cancer metastatic to his brain, and he's only got a few weeks to live. But they became close friends as roommates, and then we did, round-the-clock end-of-life care. But let me tell you quickly about Tommy, because he illustrated for me another one of those shortcomings in our own vision. So Tommy, this is Tommy, where he lived and worked in a thoroughbred racetrack called Suffolk Downs at home. And he was there from the time he was 14, never learned to read or write, but he knew horses really well. And he lived in the stables. He never had a home. He lived in the stables. And we learned from the people that came and assaulted us for not getting out to care for people there. There were at the time 400 people working in the back barns of this really magnificent thoroughbred racetrack, who were working under the table, cleaning out the stables, walking the horses, doing all the stuff you do. And they were essentially migrant workers who had no health care and no insurance and wouldn't leave, since they got paid under the table each day. If you said, well, let's bring you over to the clinic to do something, they wouldn't do that because they would lose their day's wage. So we learned a lot about them. And this is where Tommy was. This is him with one of the horse owners who's asking him for help on what to do. And he was brilliant with these horses. But this is Trish, our nurse, and we learned that these are hardworking people. They work 18 hours a day. They have one day, which is called the dark day, when they don't have to work. But we have to go to them for everything, even just to go check in on them. This is Trish doing morning rounds. I have a lesson for you here, by the way. You guys may know horses far better than I do. I live in a world where there's not many horses. But there were 1,500 horses stabled at this place, and we had a clinic that went on 3 days a week there. We actually got an old van and just had a van set up and did a clinic out there. But did you know, for the high-strung stallions in particular, if you put a goat in their stable, they calm down? Did you know this? I had no idea, but that goat is an important part of what's going on in this picture, okay? And along with Trish, but enough of that. And so what happened as Tommy was dying, we're trying to, we learned our lesson. We want to know, what do you need or what do you want? How do we make this happen for you? And Tommy had no family other than what was at the racetrack. It turns out that he told me that he wanted to be buried with the manure so that he could, sort of fertilize the rest of the world somehow. And it turns out manure and a racetrack is valuable stuff. And there's this collection of it, goes into a big bucket, and then they sell it for a lot of money to go for fertilizer, right? So he knew that, and he wanted to be fertilizer. But anyway, so we'd put him in the van once or twice a week and bring him out to the racetrack. This is him with, that's actually Byron, his roommate, pushing him in the wheelchair. That's Shirley, the horse owner. And he would go there. It was great to be there because he'd get out of the van, and he'd get out, and everybody, all the people that worked there loved him, but the horses would go crazy because, they all were like, here he is. And it was just heartwarming to see. But anyway, the next picture, I think, is the last picture I have of him. This was him, the horses just loved him, and he would smile. That's his smile, okay? And so he was dying the way he was where he wanted to be to die, is what it was. And we've learned this is really tough. If you've been, resilient but given really not much in this world, when you go to die, it's a really tricky world. And what's particularly tricky is your friends, particularly friends who are also living without homes. It's important that you honor that memory and celebrate that person. So we are constantly trying to figure out, I'm sure you are too, ways to make sure we celebrate someone who dies. And then this is a lady who finally convinced me to take pictures. Okay, so this is a woman who I knew, and I'm going to tell you in a minute about, we would go out in a van, and she lived outside on a stoop in downtown Boston near the finance district, and she was a heavy drinker. She called herself a bag lady. She never wore anything but rags. She used to have this way of keeping you away by putting all these smelly things around her. She would have milk that she bought 2 months ago, boiled eggs that were there for weeks, and just old raggedy stuff. And it was pretty effective. No one went near her. And when we were on the van, we were always trying to get her to take a sandwich or something like that. And we considered it a victory when we knew her enough and we could handle the smell that we could get her a blanket and some sandwiches. But she was a heavy drinker, ended up getting hepatitis C from a blood transfusion when she got sick and was at our hospital. And then went on, this combination of hepatitis C plus continuing to drink puts you at great risk of getting cirrhosis and primary hepatocellular carcinoma. And she her liver failed and she was going to die unless she got a liver transplant. And I don't know how it goes around here, but in Boston, it's impossible to get on the list to get a new liver. It's so tough. And they put all these restrictions on you. Usually, if you're homeless, you can't get on the list. So we had to make a devil's deal with the surgeons that if we kept her at our respite program for 6 months, so we could demonstrate what they called residential stability, and that she could stay sober for that time, they would consider putting her on the list. And she did it. She came and stayed in our respite program, and remarkably made it through all that. She really wanted to live. And when she was right up to the 6 months into it, she was right up at the top of the list waiting to get called for the surgery. She called me one day and said, would I come take her picture, right? And I caught me off guard. I'd never, to that point, I had not taken pictures of people's faces because I thought that was kind of, sort of taking advantage of people, of voyeurism or something. You just didn't want to be doing that. Anyway, so she got all dressed up. I don't know if you can appreciate this from where I am, but it's a linen dress. I have no idea where she got it. And she's got lipstick on, her hair is up in a bun. She's got her fingernails are painted. She went out and she has nice shoes on. And I'd never seen her in anything but rags, by the way. And she also went outside and got some flowers and put them in her styrofoam coffee cup. And this is at her bedside table at our old respite program. And so I took the picture. This is before cameras on phones, so I had to get a camera, which is always, that's why you see so few pictures from a long time ago and so many from now. But so I took it, and I'm an oncologist at heart, or maybe mine, not at heart. And I took the picture, I brought it back to her, I put it in a little frame, and I gave it to her, and I thought she was probably scared to death of dying. So I said, you want to talk about this big surgery coming up? Are you worried about what might happen? And she looked at me, did one of those, put her arm on my shoulder and said, oh, look, she said, you have to understand, I've been outside for 27 years. She said, at nighttime, death is everywhere. And most nights I would welcome death. So I'm not afraid of dying. And then she went on to say, and this is what took my breath away, she said, I have 2 daughters. One was 3 years old and the other was 5 years old when she last saw them. And she wanted to be sure, should they ever, this was 20-some years ago she last saw them, she wanted to be sure if they should ever go looking for their birth mother, there would be a picture of someone they could be at least a little proud of, right? And I kept thinking I had just missed the whole point of this. And it was quite, I don't have to go into more. But what was interesting also about this, I came back a couple days later to, this was in our respite program, and there were 22 people who asked to have their pictures taken. And it was a whole world that I just had never thought about. People who are looking to have something to mark that they went this way when they're looking like human beings. And that's how they would put it. And so now in our respite program, we have portraits up everywhere because that's what people wanted. I thought it would be the last thing in the world we'd ever do. And we have people get admitted now who get really upset their portrait isn't up there, so we have to, struggle to get a picture, get a portrait up there. But now, of course, there's some people who do not want that, but the vast majority of people, much to my surprise, as you get to know them and they trust you, want something like that to be dignified. So, just a lesson. Now, I'm going to shift gears for a moment. So that's kind of the backdrop, because our program is kind of, the summary of our program is that we have these 2 hospital clinics. Our docs and nurses do clinics in all of the shelters, essentially, all the family shelters and adult shelters in Boston. We have like 35 different shelters. We do those clinics, and we have a team that's out on the street in addition to our medical respite program. But anyway, the street people are the interesting ones from my selfish perspective to me. So we found that first winter time when we had clinics in all these shelters where we thought we had gone to everywhere people were to make sure the goal of this, by the way, was to not make people go to the doctors and nurses, but we go to them wherever they are. And given that surviving on the streets and the shelters is there's an immediacy to it that makes going to an appointment tomorrow or 3 days from now meaningless, that really you've got to go to them. Am I doing that? No, sorry. And so we learned that first winter time I was working that the number of people who died in Boston who were homeless turned out to be vastly weighted toward those who were living outside. And we have, as I was mentioning before, we have in Boston a shelter bed or cot for everybody who wants one, adults. In families, we have a right to shelter for families, so every family gets a place. But there are people who, for reasons that are very complicated, and I was mentioning this to Rhonda earlier, stay outside, okay, even though they could technically be inside. Now, if you say to them, why are you choosing to be outside, they get really annoyed. What they'll say is, I'm choosing not to be in an 800-bed shelter, or I'm choosing not to go somewhere where somebody who's 22 is going to tell me what to do and when to turn the lights out. Or in our town, if you're coupled, if you're an opposite sex couple, you can't stay together because shelters are either all of one or the other. And therefore, if you're in a relationship where you can't be apart, you stay outside. So that's another reason. And the best reason, not the best, but the one that shocked me most, I was out one night and it was really cold. We're on the van, and this man who I've known forever was under the bridge. It's -5 degrees. And I said, why don't you just come in for the night? It's freezing cold. Let's just go into the shelter just tonight. We can bring you over there now and you come back in the morning. And he looked at me and he said, look, Doc, appreciate what you're saying. But he said, when I go into the shelter, I can't tell which voices are mine and which voices are something else. He said, when I stay under here, I know these are my voices and I've learned how to handle them. So think of that. That's another crazy, who would have thought that's a reason to stay outside? But anyway, so we have decided that we really needed to figure out better ways to get out to where people work, where we didn't have clinics. And we started, this is what happened. Because of all those deaths on the street, the State Department of Public Health gave money to have a van go out. Check this, okay? It's a van that is run by Pine Street, but with money from the State Department of Public Health. And it goes out every single night of the year, 9 o'clock at night till 5 in the morning. And it goes out, and remember you saw how small our thing is, goes all over town. And we have somewhere in the area of 400 to 600 people who live outside. And if you think about a practice of, any of our practices, that's not too large a practice. That's a believable one, right? In fact, it's a small practice in most things. So anyway, the van, which started, I remember when it started, I tried to make it a medical nursing van because I thought that's what would be great. But the homeless people who are were put us together, nixed me in a hurry saying, we don't want doctors and nurses at 2 in the morning. We want blankets and we want soup or sandwiches or clothing or something that is some comfort of some kind. So the van does that. What they do is bring soup and sandwiches and blankets. And these are the folks who run it. These are the sort of employed by Pine Street. These are just they're the saints of this world and really the heroes in the story. And they're out all the time. Most of them have experienced homelessness at some point. Many are in recovery. They're very diverse, but the common thread to their approach is they never judge anybody. They're just out there. They bring soup and sandwiches, and since they're there every night, they know everybody outside. So I've been, for at least from 85 until COVID, I rode in that van 2 nights a week and learned that if I got used to serving sandwiches and blankets, you can sort of then say, I'm a doctor. If you need anything, we can go on. And it's been like my sacred territory. This is like the coldest night of the year. We still had 100 people during a snowstorm, northeaster, sleeping outside. And this is, one of the van folks going up to give some soup and sandwiches to this guy who's sleeping on Trinity Church, which is our local thing. And I took this picture. There's a million pictures I could show you about life on the street, but you know all that and you don't need to do it. But this is a 92-year-old woman who's outside all winter. You can see her legs are red, and we are frightened to death about how to get her in, coax her in. And despite giving her blankets and soup and whatever we can, she would never come in. And it took us all winter long to finally coax her in, although I used to worry every night that we were neglecting her and she would die. So the struggle between, when you go outside, and all of you may know this if you've been out doing street stuff, struggle is when is somebody really not making rational, good decisions and in danger of dying, and you should be bringing them in against their will, or just letting people make their own choices. And I won't even begin to tell you how hard that thing is. It's really, really difficult. And the one story I can share with you, which freaks me out, there are two stories that freak me out about the street. One was one of the first nights I was on the van. It's 2 a.m. We're under a bridge by the river. I've got my flashlight looking at something, and I see this guy to see if he wants anything. He jumps up. He's really irritated with me, and he said, "Look, buddy, how would you like your doctor showing up in your bedroom at 2 a.m. unannounced, right?" And if you think about it, it's pretty invasive what we do. You know, they're not asking to come to us. We're going to them, and it can be any time of night. So I panicked on that one because I said, "You're right. I shouldn't be doing this." And then we had that group of what we call a consumer advisory board now, those people I showed you in the beginning, got together and they brought a whole bunch of people from the street and they talked about how they wanted to be served. Without it, we weren't allowed to be there. And it turned out they all agreed that they wanted us to sort of go check on them at nighttime. They wanted that. But what they hated, I didn't think about that, was we have these flashlights we're shining in their face, right? And they didn't know who we were. So, you know, when the flashlight comes, all you see is light coming at you. So we now have to shine the flashlights on our faces, not on theirs. And that was the compromise. Then the second thing that I remember really about this dilemma of when to bring people in is a woman who we knew for years outside used to be angry at everybody, and our goal at nighttime on the van was to slowly over time get her to trust us so we could give her some soup and give her some blankets and have a conversation. And it took after about, I would say, 5 or 7 years, she started to trust us. We'd been there consistently, and she would say, talk to us. And then one night she wasn't there. She was gone. And I learned later on that she had lost it during the day, had said something to a passerby or something. The police brought her into the hospital where she was admitted for psychiatric care. And then we didn't see her anymore. And I went to a meeting a couple of years later, and I'm down at a meeting at a shelter on the South Shore of Boston, and I see her. She's all dressed. She's on the board of directors of this shelter down on the South Shore. And I went up to say, "Wow, you look wonderful. Congratulations. What's been going on?" She looked at me and she said, if you forgive my language, she said, "You effing bastard." She said, "You left me out there for 10 years and you never did anything." And I froze. She said, "I was sick and you didn't even help me." So we don't know anymore, and we struggle as a team. We talk about this all the time about where is that line. And so just keep that in mind. There's always a tricky line. She would argue that we should help people who can't help themselves. She said, "If I had a big gaping wound, you would have jumped all over me. But because my mind had the big gaping wound, you let me be there." So who knows? I don't know. I'm not trying to push one side or another, just to say it's very tricky. Just to give you, by the way, I went to medical school. You remember that? And I used to sit in rooms like this, and I could get incredibly bored. So if you're bored, you should just let me know, okay? Because I have this dread fear of, oh God, you're going to be like me in the back row feeling, what this guy talking about? So feel free to jump in and jump all over me if that happens. But because I could go on forever, and you don't want me to do that, right? So this is Greg, who I thought to give you a feel for some of the folks, and I grew to love this guy. So Greg, who asked me to take that picture, by the way, because the Citgo sign is by Fenway Park where the Red Sox play, and that's in Boston. That's the classic place to be. And he's holding a cigarette that he doesn't even smoke, right? Because that's cool. But he wanted that picture, so I took that picture. And this is where he lived. This is where Storer Drive in Boston, which comes along, meets Route 1, and those roads are supported by these big I-beams. And he and his mother and his sister, along with about 40 people, are living out of sight inside those right now in that picture, right? And he was all of 16 years old with his mom, and I think you can see it better. So this is us going to the van. See where their I-beams, and then they put boards across the bottom of the I-beams, and then they crawl up and sleep in there. And while you're out of sight and out of the rain and snow, it's still pretty cold and close up there, pretty dangerous. So they would throw a rope down, we'd tie the sandwiches to that, and then they bring the rope up. But Greg lived up there with his mother and his sister, and as I got to know him, see if I've got another picture. There you can see it a little bit better how the boards go. But this is Greg when he came. We finally lured him into our McGinnis house, and he, when I got him there, he said he had one sister who had a place, and could he give her a call? And I said, sure. And I gave him the phone, said, call, feel free. And they pushed the phone back at me because it wasn't a dial phone, but you push the buttons. He couldn't read the numbers, right? And so I started to realize this guy, he couldn't read or write. He's been out under a bridge since he was 16. And he has this dense stutter. When he goes to talk to you, especially if he gets excited, he just stuttered. And he's sort of a big, imposing guy, so he's always in fights. He got labeled as a bad kid because he was fighting with the people who made fun of his stutter. And as we learn more about him, it turns out, we finally got him into some kind of care, and it turns out he had an IQ of about 48. He had never had any services. He had lived in chaos in some part of town. And you think about, what's this kid going to do? He's living outside. It's not a question of rehabilitation. This poor person has just never been given a chance. And all of that stuff should have been caught when he was a kid, but we missed it. And I could give you stories and stories. But anyway, he taught us a lesson about, and he's the sweetest human being you'd want to know, but he just had been given nothing. And this is Greg about 15 years after that picture with his best friend, whose name is Billy. This is Greg about 2 months before he dies of lung cancer at the age of 51. And Billy, who's with him, who's his best friend, and they're I took this when we were at Mass General in the clinic, and Billy is sitting there, and they both are kind of, they're people if you saw them on the street, you'd say, get a job, and they're kind of like, what's going on? But as you learn more certainly about what Greg went through, and then you talk to Billy, it turns out in 1968, he was 5 years old. And we had riots in Boston after Martin Luther King Jr. was assassinated, and he was caught in his neighborhood. Somebody poured gasoline all over him and set him on fire. 5 years old. And what you can't see here is that everything from his neck down is burned, right? And he was in the hospital for about almost 2 years, had, who knows, 130 surgeries or something like that. And then because he lived in utter poverty, never really got follow-up after that and was on the streets basically living with Greg. And now he's got AIDS, he's got terrible rheumatoid arthritis, and he's got diabetes way out of control, right? And he's got this skin that just tortures him because he keeps getting contractions. And I kept thinking, if you knew the story behind these two guys, you would just be sympathetic. But if you didn't know the story, you'd say, all these services you're doing are a failure, something like that. So it's way complicated. And what I sort of learned this morning, and I know you guys know all too well, is that appreciating that complexity gives you a huge amount of space to let people be who they are and to take time to get to know them. And Billy died. He had a stroke believe it or not, he died from low blood sugar. Somebody tried to treat him too tightly, and we learned if you're on the streets, don't go too tight, stay up, because low blood pressure kills you. Low sugar kills you. High sugar you can usually treat. But anyway, little stuff from life on the street. And then we had a whole bunch, we've done a lot of, I'm going to not bore you with this, we've done a lot of studies on mortality on the streets and stuff like that. We could talk about this forever, but suffice it to say, people in Boston, like in San Francisco, Atlanta, where they've done studies, will die at 4 times the rate of if you're in a shelter, they die at 4 times the rate of somebody the same age who's got a house in the city. So there's a 4-fold increase in mortality by being homeless. We don't know why, by the way. It's just, it's not, it's a whole bunch of complicated reasons. It's not one set reason, but it is consistently a 4-fold thing. If you live on the streets, as I'll show you in a minute, it's 12 times, not 4 times. So these people that I used to think were these rough, tough, sturdy survivalists, may be that today, but they don't live if you follow for a year or 2 or 3. They have the highest mortality rate we know. So anyway, that alarmed us, and we were trying to figure out, in addition to nighttime, we better get out during the day, because nighttime you can do a lot, but most things are closed. Everything's closed. We could get people into the hospital or into detox at night, but we couldn't get them into the regular services. So we started going out many years ago, this is in the 90s, as a team during the daytime to catch up with people. And just to let you know, in Boston, the nighttime the van works because there's no traffic. You can't take a van out in Boston during the day because you'd be sitting in traffic all day. So you have to walk. And so our teams basically walk the streets during the day. And we start, though, by doing, this is what's called a Finagle a Bagel. It's a downtown coffee shop, and we just do rounds. We start there, and most homeless people, they have paperwork or something to do, can come, and we'll do the paperwork there before we take off. And actually, Pat, who's one of our doctors at this time, was writing out a housing form for Rick there. The other two, one's our physician assistant, and the other a nurse practitioner, helping this man get into detox at that time. But it's kind of cool because you get to be part, instead of in the hospital or in the clinic, you get to go out and do that. And then after that, we get to go out and follow people. And the joy of this, which is what I would love to talk to people about later, is that we learned that we couldn't go out, like you can't send medicine out or nursing out or this out. I mean, you can, but the ideal is you go out together so that if somebody needs, psychiatry or needs therapy or needs recovery, you're all together and you don't have to refer to another institution. So this is I love this old picture. It's Eileen is in the red hair there. She's a psychiatrist who works with us on the street, has been doing so since 1995. And I saw someone here who worked at the Women's Lunch Place. Who was that who worked? Anyway, Eileen was a founder of the Women's Lunch Place, wherever you are, back in 1982. And then Kendall's a therapist, and our nurse you can't see is around the corner. But it's great because, I can be talking about the medical stuff, but it's a psychiatric or behavioral health issue. There's someone there to talk to them at the same time. And then we can sort of get to know them and lure them in. But I say that very selfishly. I love this picture because this is our nurse with Katie, and it's our nurse, Katie, actually they're both called Katie, and Katie, and the second one to the left is our psychiatrist, our current psychiatrist, who's been with us the last 4 years. And, on the other side is Becky, who's our nurse practitioner, with this man who lives in an alleyway. And then he gets to, he has all his team come right and see him there rather than him having to go somewhere else. So that old concept of you got to go to where they are sometimes works. It's always nice if they will come to you, but if they don't, you got to go to them. And I threw this in there because this was my lesson. This is a man who we've known forever, who had come in and he was a heavy smoker, and he let us do lung cancer screening. This is many, many years ago. And we saw a nodule on his lung that looks like it's cancer. And what we have to do now is get tissue to know what kind of cancer so we can treat it. But he's like too paranoid. He said, I'm not going to let you put a needle in my chest. So he works some day labor job. And this is down in McDonald's, down in what's called Faneuil Hall in our town. And we would sit with him. And that's Pat on the left, on the right, who's our doctor. And Eileen, the psychiatrist, along with Cheryl, our nurse. And Eileen's brilliant about working through people's paranoia and what they're worried about. So with the promise of the promise of a lot of benzodiazepines, he agreed to come in and get the biopsy with her being with him. And we got it, and it turned out it was a lung cancer, but early enough that he had surgery, and, he's still alive. This is 25 years ago. He's still alive. But we would never have been able to do that unless we were working together. So that's my appeal to say, wouldn't it be nice if the world would let us all work more closely together and gave us the time to do that? And I got challenged, along with a bunch of our doctors, about what goes on in the clinic that requires the privacy of a clinic that couldn't be done somewhere else. And, we stuck to, we need the privacy of the clinic, intimacy of the clinic to be able, or the clinic exam room to do it. And our nurses, by the way, it's nurses again, sort of said, oh yeah, tell me, and then we started to parse it out. It turns out about 80% of everything we do that we learn to do in the clinic, you could do very comfortably, at a park bench or at a McDonald's. As long as you don't worry about the privacy issue, which you can get around. But anyway, so we had to think about it. And this is Dave Munson, who's the doctor that I work with on our team. I like to point out that he's half my age and twice as good. But this is a woman who's 82 years old. She has terrible heart failure. She doesn't come into the hospital unless an ambulance brings her in when she's in basically pulmonary edema. And so she won't go to the hospital, but she lives here in around South Station. This is our Amtrak station. And she was perfectly happy to let us go and do all her care right there, but she won't go to the hospital. So we thought that was pretty delicate stuff because she's got heart failure. Her ejection fraction, for those of you who care, was about 12%. But she said, you can do it. You can listen to my lungs here. You can weigh her. We could take her bloods. There was a CVS right next to her, so we could change her medicine. And we found that she would let us do that and manage her Lasix and everything else at the time, torsemide now. And we would just keep in touch with the heart failure clinic at Mass General, who'd tell us what to do if we were in trouble. So for 10 years, we took care of our heart failure there, when I would have told you before this started that you can't do it outside. You got to bring these people in for their care. So there's a lot to be learned, I think, for all of us about what strategies we can use to get to people and give them much better care on their terms rather than our terms. And I love that picture. And then we also learned, this is where dermatology and telemedicine came in, okay? So for those of you who don't, if you're not in medicine or looking at stuff, this is a man living under a bridge who thinks he has scabies and has been in 6 emergency rooms and is pissed off at the system because they keep treating him and he never gets any better. So he's under a bridge now. He won't go back into the hospital. So he let us take a picture. This is what I remember. When did the cameras first come out? I can't remember. Cameras on phones, whenever, maybe 2008 or 7 or something like that. But anyway, so he let me take a picture. And for those of you who are knowledgeable, that looks a little bit like Norwegian scabies on his back, if you've ever seen Norwegian scabies, clustered scabies. But he's got this stuff on his neck. Can you see these nodules around his neck? You see if that's it. He's got these nodules around his neck, and that's not scabies, right? So I don't know what's going on, but I now know it's not scabies. But we got to send this picture to Ernesto, the dermatologist, just emailed it to him. And dermatologists, can make an accurate diagnosis about 80 to 85% of the time with a good picture. And when they can't make a diagnosis, then that's somebody you've got to get in. And so I had, when I was training, I had done dermatology rotations under Ernesto. So he wrote back this kind of harumph email saying, we talked about that many times. And I was like, okay, here it comes. And then he said, that's nummular psoriasis. That's not, and he'd been in 6 emergency rooms, right? And so he showed us how to treat it, which you all know. And this is like, 3 weeks later, the guy's much better. And he thinks now we're the best doctors that ever existed, right? And it was our first sort of specialty consult under a bridge by telemedicine. But it works. So, whenever you can, those are always options. That specialist could be 3,000 miles away. It's okay. You can get strategy in that. And here I am living in the lowest tech world I could ever imagine using, at the time, early telemedicine, right? Now, the other thing that I would point out, sort of as much a public health thing as anything else, is that there's the investment in getting to know people, which of course Medicare and Medicaid are not going to pay you to do, okay? I think the return on that investment is huge, but nobody appreciates it because it happens down the line. Like that man who we soaked his feet for 6 weeks to save another 25 years of treatment-resistant schizophrenia, right? So what we learned is when we first went out, if we said, hey, would you get a flu shot? Everybody told us, no, not in your life. And then we asked women, when was your last pap smear or mammogram? And almost none of the women living on the streets could remember the last time they had one. And they had no interest in getting one. And we thought, well, how are we going to ever offer really good quality care if we can't even meet basic quality measures? And it turns out over time, particularly when you have great women doctors and nurse practitioners and PAs, that as they get to know the women better, if they were to say to the women, can I, I'll do your pap smear, can I do this, somewhere, the women more often than not would say yes. And if you could come into the clinic where we were and we could take them up and do the mammogram, they'd do it. Or what we learned even more invaluably is every time they were admitted for pneumonia or something like that, it's a chance to do all the screening that you can't do when they're outside. And it's really easy to do when they're sitting there with nothing to do for 4 days. You can do that stuff. So we now, have the same pap smear and mammogram, scores as everybody else in our fixed site clinics. So it's pretty cool. But this is flu shot season. We learned that as we get to know people on the street, they would all say yes to a flu shot if the person giving it to them knows them. When I say all, there are some that will say no, but vast majority. And I love this picture because that's another one of Pat Perry, who had talked to this guy about, can I give you a flu shot? And the guy looked at him and said, not in your life, buddy. And Jill, who's our physician assistant, who had known this man for a long time, comes up and says, oh, John, let me give you a quick flu shot. And he pulls up his thing, sure. And this is Pat going, are you kidding me? But it was a lesson for all of us. It's all about the relationship, and I swear relationships result in much better public health measures. So, and I won't talk about COVID because you guys have lived through it. It's terrible, but we got caught, among the many other things, it sounds like we had the same thing that Neighborhood Health had, is we got picked on to be the place where anyone who's homeless, who had COVID, needed isolation, had to come to us. Made us turn our whole lives around. But we had to run, this was a 500-bed pop-up hospital in the convention center, which we had to run for homeless people who had COVID or who had been exposed and needed to be isolated. It was a nightmare, but save that. But the vaccines came out, and the same thing happened, okay? And this is so dangerous. This is Jen Nunes, who's our PA, giving vaccines at a park which we call Mousy Park. It's a classic place where all the homeless people gathered in this part of town. And it's on the grounds of Mass General Hospital, so we were very attached to it. But we had, I think, 3 people say no to a COVID vaccine on the streets. Not because, I think because it was Jen or one of us giving it to them right there. If we had said go get it at the clinic, it's wide open now, nobody would go. So there's a lot to be said for that. So we were kind of lucky in all that. And so I just share that with you as just an observation. And then the thing that we also realize, and this, I was talking to you, that this is where we differ from where you are, because we live in a world, we can't walk 2 blocks and not hit another hospital, right? So having a connection to the hospital where the specialists are and where the imaging is and where all the stuff we need for many people is, having it. So Mass General is where the street population hangs around down there. So we have our street clinic there. Our Boston Medical Center clinic, which is way busier, is where most of the people in shelters will go. But we realize we have a clinic dedicated to people on the street, because remember, they're coming off the street, they can't shower, they're a mess, and they feel terrible when they go into hospital, unless you can make it comfortable for them. And Mass General, to their credit, let us have a special exam room. We have coffee and donuts that they supply, and everybody can come in. It's like a community gathering. It was initially on Thursday, now it's most days. And I don't know if you can appreciate, I took this picture without realizing till a medical student pointed out that there's somebody sleeping under the table. Can you see that? So it's a pretty crazy, wonderful world. And this is our nurse just taking vital signs. And just that alone is kind of like, wow, they get to do that. And here's our Stephanie, who's our remarkably wonderful nurse, outside the clinic waiting space saying hello to this woman who we had coaxed in from the night before. We had spent 2 years getting her to come in. This is where she stays out. This is all her stuff. She lives on that step. You can see her under a blanket up there. And she's feisty, wonderful, lovable, but just resistant to coming into care. And she has, for those of you who know, diabetes very well. Her hemoglobin A1C is 19, okay? And we are desperate to get her in. So she finally came in. And now she, from there we were able to get her in, and now she's in a nursing home, and she's the head of the patient, whatever the patient consult is at this nursing home. And she's wonderful. But it took us years to convince her to come in, and it took a lot of trust to do that, but kind of fun. And the other thing about the clinic, which all of you know, and I'm sure this is it, it's a place where you can have students and residents, everybody. It's a community, and this is several students with several patients, and all those students, by the way, went on to become doctors or anthropologists, now that I think about it. But it's a fun time, and it's a chance to get people to see what the work is all about. And we now have 35 full-time doctors in our program, and I would say 80% of them were students with us coming through. So it's also a great place to recruit folks to come do your work. This was Valentine's Day. I don't know why the yellow roses, but it was Valentine's Day. Those roses were brought in by this man who's one of our favorites, who about a month after that was stabbed to death. And then a story, I probably should, I don't listen to me. Are you guys okay? Am I talking too much here? Are you okay? A story, okay. So this is 2 favorite patients of mine, okay. Brad, who's standing up, was a Green Beret in Vietnam. And for those of you not around during Vietnam, these are the crazy guys. They went into the tunnels. They were maniacs, but really proud. And I don't know what happened. Brad did 2 tours in Vietnam, came over and was on the streets. Never told me why, just was on the streets. And then I ran into him many years later, obviously. And then he befriended Charles, who's sitting there, who's about half his age. Charles is the opposite of a Green Beret. But they became really amazingly friendly and took care of one another. And Charles was the first person that I took care of with AIDS, who was what they call a long-term non-responder, so he never got sick. And he was convinced, he had this kind of very complicated, this is back in the 80s, so this was 1986 when I think we diagnosed him. And then he was convinced he had this diet that I would call vegan now. He didn't call it vegan, but it had a lot of kale and a lot of other stuff. And he was convinced that diet was keeping the virus at bay. And that was it. And so he's come in now because after, this is now 2000, this is 30 years almost after the first picture, after we first met him. And his viral load is going up, his CD4 count is going down for the first time, we don't know why. And he looks at me, and I give him the whole story. I said, Brad, this is great, you lived long enough, now we have a 1 pill a day, this will keep you perfectly okay, and it's easy to do, and you trust me, right? Let's do this pill. And he was like, yeah, doc, I sort of trust you, and this is 30 years later. He said, but I know what happened. And he had truthfully eliminated kale from his diet because he thought it was giving him GI distress. So I'm going to put my kale back and I'll be all set. And then 3 weeks after this picture was taken, he came in with pneumocystis pneumonia and died in the hospital. And we had been he had gotten housed, by the way, and we were visiting him at home a lot. And it was a crusher. This is something we could completely have prevented. And we had spent years, decades getting to know him, and he trusted us and all that. So sometimes it's not all, you need more than that. And then have to respect him saying, I won't take the pills. What was devastating, though, is that Brad, who by this time, they were real partners by now, Brad was devastated and went into this deep grieving stage. And we would go see him at home, and I'd always drag Jim Bonner, our psychiatrist, with us, because, grief is pretty profound, usually can last a month or two, but he went on much longer than that. We couldn't figure out what's going on. So we actually had to bring him against his will to the hospital because he wasn't eating, he was sitting in bed. And we brought him to the hospital, and he had lung cancer that had completely infiltrated his brain. And his grieving was complicated by the fact that he had metastatic lung cancer. And he died within 6 months of the time that Charles, his partner, had died. And I was digging through my things, and this is a picture I took of them 30 years before that picture, right? When they decided at the shelter at Long Island, the one I showed you in the beginning, that they were going to get married. And this is before Massachusetts had any rules and regulations. And if you've been in shelters, the politics in shelters are pretty raw. And it was gutsy for them to do that. But they decided they'd do it, and this was their wedding picture they asked me to take. And I wish I had had a good camera so I could have gotten a good picture. But they get married at the shelter, which has 500 people, and I would say 450 of them were there to be under the tent to have the wedding ceremony. And they get married. And 35 years later, they're still together. So it's a kind of a wildly interesting and wonderful love story with all its ups and downs, but they stuck together. And it was not easy, as you can imagine. And I think should I keep going or stop? I need to check in here, you guys. Are you bored? Huh? I feel comfortable either way. I'm looking at these people and saying, do you need to go to the bathroom or have a coffee, or are you okay? The chairs, okay. Thank you. So sweet of you to say that. The chairs and not the speaker, okay. I think, I could go on and tell you more stories of what I have come to think of as the continuity of care that becomes so important for a segment of the population that really needs accompaniment, right? And but I think I'm going to stop there and invite questions, okay? And if other things come up, I have a whole lot on what happens when people get into housing, but I want to spare that for a little bit. Unless you think I should, Wanda. No, I'm okay. Okay. So don't be shy. Oh, yes. God, somebody in the back row asked a question. We used to sit there so that we wouldn't ask questions.
Hey,
Thank
Doc.
you.
Thank you. Chaplain Rico here. Appreciate you coming out. Wow. A lot of story, great memory for you, and thank you for sharing. I do have a question about not only your engagement, but what would you say was the most traumatic engagement you personally have had?
Ooh, no one's ever asked me that question. And it's a great question. I should know an answer right away. I would, well, first of all, the thing that I remember most are people dying. So one of the tough things, and I ask you guys this whole thing, as you get really close to people and see what they've struggled through, and the courage that they're living their lives with, given that they've given nothing, and how we still exclude them from our society. And when they die prematurely, often with no one around, it just is heartbreaking. And then you feel like you've failed. And I think on our team, I think that's when we most rely on teamwork, because one or two of us will be utterly devastated, and that you can get a little bit of comfort from the others. But I can think of, there are several people, I'm sort of stuck by who's dying most recently, but somebody just died last week who we'd known for almost 40 years. And it was just crushing to see him go. He lived to be 80 years old, though, which we had to think was a victory. But losing him, made it feel like, oh God, what did we do? Did we do anything right? So I think it's that torture of, we're getting to know people and doing everything we can for them, but is it enough? And did we fail them? That's where we get a little devastated. In the end, I don't think we did, by the way. I would make an argument if I know, but the feeling of that is really awful.
Thank you, thank you, Doctor.
I will show, wait a minute, go, yeah, I'm sorry, yes?
How do you, sorry about that.
Right
I just, when you were showing the photo of the COVID vaccinations in the park near the hospital, I'm curious, percentages of, because of the series of the vaccinations and that protocol, like how did you manage that? Did you have a lot of return patients, or that seems like it would be tough to manage?
It's a great question, because there's the vaccine came, and then there's the booster, and then there's the booster, and then there's the booster. So and we've decided to just combine those with our flu shots each year. But surprisingly, most of the people, because we have a system in place, and remember, this is a group of people that we know and follow, so we can pretty much, I would say, almost everybody stayed up to date, which is kind of interesting. But we had to. Had to concentrate on doing that. And we had to not rely on the flu clinic at the hospital or the flu. That was the other hard part. But another interesting just observation, we had 40% of everybody living in a shelter in Boston got COVID during the first or second wave. It was devastating, okay? And when somebody's in a 500 or 800 bed shelter and is exposed or has COVID, where do you put them, where do you isolate them? So you must have had that. We didn't have any motels or anything like that. We actually made these really specialized tents like we would do in Haiti during an earthquake with negative pressure rooms and all that stuff, so we could just isolate people or quarantine them. And then we ended up with that crazy hospital at the convention center, which was 500 beds in a huge space, which turned out to be great fun because everybody there could be normal because they were all exposed or they had it, and it was kind of like a blessing. Everywhere else you had to gown and glove and do everything else. But no, for some reason the observation was that the people who truly lived outside in Boston, none of them got COVID. None. The only ones who got it would be if they went into a hospital or in a nursing home for a short time, they would get COVID. But it was interesting, early on we realized the transmission of this outside is really not clear. We argued with CDC for a long time. But I don't know if you remember when we had all the George Floyd marches and everyone was worried about it. No one ever got COVID in any of those. They were outside. So interesting, just epidemiological thing to think about. So we may be a little bit, the fact that so many people outside didn't get it, we're not sure our vaccines are stopping them from getting it or just they're outside and it helps. Great question. There was somebody we turned off. Somebody else had a question way over there. Yes?
How do you practice self-care?
I have a short answer to that, which is no. No, and it's a great question. We talk about that a lot. I think early on, and this is something I'm not proud of at all, but early on it was so busy. It was TB, it was AIDS, it was no one around, and we just felt the weight of the world on our shoulders. So we worked, I don't know if any of you are going to be residents, but we worked like we were residents. It was 90, 100 hours a week, and we didn't think about a balance between life and work. And that was a huge mistake. We shouldn't have done that. And now we don't allow, we just don't allow people to do that anymore. But sometimes in the beginning, when you're just a few, you do these things that I would question whether it was as smart as I used to think it was. So no, the answer was we did. I do now. Now that I'm in my late 70s, I take care of myself.
have a question for you, doctor. You had mentioned the difference between clinical medicine and street medicine and how the team was going to the street to provide medication management, if I understood correctly. And my question is, you mentioned the barbers, was it at a restaurant or a bar? I wasn't sure, I didn't grab that.
It was a bar, it was very much an Irish bar, I promise you.
And was that through the suggestion of your patient that they felt comfortable taking their medication at that location, or was it more of a group effort of your team going to the community, asking for that support to assist with that concept of street medicine? Where did that idea stem from?
You know, I think since this happened, like within the first couple months we started, we knew, we could always go to the homeless people we were serving to say, what do we do? And they were the ones that said, you can't expect them to come in every day. You got to figure out places for them to get their medicines. So I think we knew we had permission from our board. And what we ended up doing, I think, was offering it to the people, saying, if you're having a drink there, do you mind taking your medicine there? And most people were like, sure. You know, it was not a big deal. And we didn't force anybody to do it. It was just, the bartender used his own little magic on it, but I didn't look at that. But there was no arm twisting, just begging. But it's a great, so the other point you're bringing up is, like street medicine you'll hear a lot about now, and I think it's like wonderful and beyond wonderful that people are finally paying attention to the people that have been outside and can't make it into the mainstream systems. And in our traditional systems, even our more aggressive traditional systems, haven't been able to reach them. So the concept of getting out to wherever they are with the social workers and the caseworkers and everybody else, but also the doctors and the nurses and the psychiatrists get out there, I think is a concept that is, to me, is an extension of what healthcare for homeless people is, because we do that. We went out to the shelters where everybody was, but then we had to also go out to the streets. So we didn't separate it, like the medicine itself isn't different. The location and the surrounding was different. So I think that's the only thing I was trying to distinguish. So when we were doing everything in shelters or in hospital clinics and realized there was a huge need outside, we just added that and didn't think of it as street medicine versus shelter medicine, just a more how you take care of homeless people. But I realize everyone's going to see that differently. My big concern always is the mandate for us was not to do a separate healthcare system for homeless people. So whatever you're doing, try to figure out ways you can integrate that into whatever the care is in your community. And I think you're already doing that really amazingly well. Did that answer your question? No, it may not. If you're shaking your like.
No, you definitely did. But just another quick question to follow up. You mentioned that you had to obtain permission from the board. Was that challenging?
No, I could talk to you forever. So it was not as challenging as you might think. What it was comforting, because we could go to them and say, what should we do? How do you want to be served? And they would guide us. So it felt good when you're going out to do something, the people you're going to serve were involved in telling you what you needed to do. So for us, it became a huge comfort. And to this day, there are 5 homeless or formerly homeless people on our board of directors. And we're like a $90 million a year program with 700 staff. But they hire, they're involved in the hiring and firing of us. So we are beholden to the people we serve. And I think that's a great way to be. It's much better than being beholden to the board at the hospital, if you know what I mean. Yes, I'm sorry, yeah. Oh, thank you if you do that, yeah.
I was just wondering, for some of us that are going through our medical education right now, what kind of experiences did you have or wish you had that helped prepare you for this kind of career?
Yeah, I was almost trying to be flip to say I'm so sorry for you here, but no, it's a great question, because I struggle a little bit with this because we have so many people we're trying to lure in. And one of the challenges early on, which I was facing, was there was no career path to do this. You could do it for a year or do it for 3 months, but you couldn't do the continuity of care because there was just no way to get paid. In fact, for years we didn't really get paid very much. We had to take a second job to pay your rent. So that was always the goal. How do you make this? Because we knew people were sick enough. This is great medicine, great nursing. You can't beat it. It's so complicated. But how do you sustain a career doing that? And it has to be done as a team. You have to figure out how to make sure people don't have to suffer too much financially. And then you have to make sure they're welcomed into a system. You don't want to feel like you're an outlier. And I think that is clear. Now, medical school, since when I was in medical school, do you guys know Paul Farmer? Have you ever heard of Paul Farmer? Okay, so Paul was a student when I was first starting at Pine Street. He was a student, and he came down to Pine Street when we had that TB outbreak, and he was fascinated by TB. So he took what we were doing in inner city Boston with the multi-drug resistant thing and brought it down to Peru, and that's how they did their TB in Peru. And so we made this interesting connection where what goes on in the inner city of many of our towns and cities is often more akin to what happens in third world countries than what happens in first world countries. And that seems to be a shame, right? We should be able to fix that. But when he came, he taught me a lot about he was a student, and Paul was like never really a student. He was really way above anything like that. But for those of you who don't know, Paul Farmer was the subject of a book called Mountains Beyond Mountains. He started Partners in Health, did huge amounts of healthcare in Haiti and then later in Peru, Rwanda, Lesotho, and lots of other Africa. And he died prematurely at age 62 about 3 years ago. But he's sort of a hero to most of us. Anyway, what we used to talk about in school, you have very few opportunities that are substantial when you're in medical school, right? And I've come to believe that maybe that's okay. You'll have plenty of opportunities later. Your job in medical school, this is me talking now, is to we want you to be really good. If you're going to come work with us, be really good. And the way to get really good is to just do what is required in medical school. At least in the old days, that was a full-time. It was hard to do much else. Now I'm always astonished when students come and spend a month or it's quite astonishing. But I wouldn't honestly worry about it. When you become a resident, you can start to do little bits and pieces. And then afterwards, take a job in a community health center or a place that does this kind of work, and you'll be incredibly well trained and ready to then learn what they need to do. Nothing that I would have learned in medical school would have helped me when I got to Pine Street. I had to learn once I got there. So that's kind of the lesson I would share with you. It's your heart and what you look to be doing that you really want to. And then when you're in the hospital and doing that, take good care of these folks. There's nothing, our patients, if I can say that for a moment, if we say to them, what's the most important thing we do? We think of all these other things. It is visiting them and talking to them when we're in the hospital. That's when they're most scared and most want someone. And students can be the perfect way to visit people. When you're doing your rotations, take good care of these lonely people sitting in a hospital who really need someone to talk to. And then you'll learn everything you need to know.
Yep. Right here. So Rhonda and I are the co-chairs of the Yakima County Healthcare Coalition. Dan Ferguson, I work with the community college system and also our local accountable community of health. I'm really curious around the early stages of coalition building and all the people you brought together and the lessons that you learned or wish you had learned early on in terms of building those partnerships and relationships. I was just wondering if you could say a little bit more about that. Thanks.
Yeah, and that's a great question, Dan, and I think about that, I do way too much time now reflecting on what went on rather than looking ahead, but that's one of the problems. So I think the reason I show that, one of the things that was really important for me personally was to be dispelled right away of my own. I thought I understood the community. I didn't. I had never been in the community, didn't know it. And those homeless people getting together and telling us what they wanted, and the nurses in the shelter saying, here's how you're going to do it, was the best thing that ever happened to me. So the coalition building began not by choice, but because if I wanted to do my job, I had to work with them. And then we had the added advantage of the homeless people said we had to be part of the hospital, so we had to work with the chiefs of medicine at both the hospitals to make sure we were integrated into that care. So those relationships, which are now 40 years old, have been, as you can imagine, up and down and all that, but we are firmly inside. But it took a lot of time in the beginning. So we had to be part of think of this, we are the guests in about 40 places in Boston. So each one of those requires some sort of, negotiation. And always making sure you're doing what they want you to do as opposed to what we think we want to do, and then trying to gain enough stature so you can negotiate that with them. And that took a very, very long time. And so when I talk now, I'm talking too far down the line. If you had asked me this when 1989, I would be saying something totally different. So it is time that it took. I think finally what I would add, we talk a lot about this, about advocacy. And since we got so burned in the beginning about the advocates were really clear what they wanted to do and didn't want us in the way of that. And so when we had to then put our heads down and work for 5 years, we sort of earned our keep at that point, and then the advocates invited us in because we sort of knew what we were doing and were part of the community. But if we had tried to do that in the first month or the 6th month or something, we would have been cast out of the shelter. So there's a lot of that, doing your work well, being a witness well, means that the people that matter are going to ask you, what are you seeing, what are you doing, and you become a witness rather than a staunch screamer on the other side. Does that make sense? And all of that is a gamish of what we ended up having to do, and sometimes well and sometimes not so well.
Hello? Okay. So what does your street team do to welcome folks that have pets like dogs and animals? We have so many of our street folks that don't want to leave their dogs behind, and that makes it very difficult for us to get them into respite or get them into housing for sure. Is there any way that your team deals with that we might learn from?
I don't know if you'll learn from us, but I can tell you how we deal with it. We have like mixed feelings about pets because we love pets, but in general, pets who are living outside with our folks don't get treated very well. And it's very hard for someone who's living outside to actually take good care of a pet. But at the same time, they're great protection and they're great companions, so we never get in the way of that. But it is exactly that. If we need somebody to come into the hospital, into respite program because they're really sick or their blood sugar is out of control, they're not going to leave their spot if there's a pet there. So we've had to learn how to, this is unofficial, but we just take the pet home with us. One of us takes the pet home and takes care of it. But they will only do that if they know who you are and trust you. And then they'll come in. But that's a lot of work. And then it doubles up when they get into housing and they have a pet. So then, especially in our town, we have mostly scattered sites. So you're alone in an apartment. You're not in a group home of any kind. And then we can't get people out of their apartment because they won't leave their cat behind or their dog behind. So it becomes, a realistic and important obstacle, but it can be overcome. It just adds a whole nother dimension. And then we have vets who come with us we'll visit people. We do a lot of home visits to our friends, and sometimes we have to bring the vet with us to the home visit so the dog will be taken care of. And then we have to do a lot of, making sure we get nutritious food for the dog as well as for the person. So food banks for dogs are the other interesting thing. But I was going to tell you a story that involves a pet that really we struggled with, but I spared you that. And if we have time, I'll tell you that at the very end. But it's a huge, huge issue.
Hi, my name's Meredith, and I'm a legal aid attorney here in Yakima. And we deal with a lot of folks who are housed now, but are having trouble staying housed because of a mental health issue. And that could be a behavioral issue or something like hoarding. And some of them may have regular appointments with folks where they go see a mental health care provider. But I'm wondering if any part of your program involved going into people's homes to help them address mental health issues, because they will often lie and say they're doing fine with their hoarding, and in fact, they're not, and they're facing eviction, and a lot of times their mental health providers don't even know that. So it's a need I've seen in this community, and I was wondering if your program has done any of that.
Yeah, and the answer is yes. We do a ton of, just our street team alone, I think we did 2,000 home visits last year to street people now in housing. And we're not they're in places that have case managers and other stuff. We bring the health care in. And when we go, we always go with a medical person and a behavioral health or psychiatrist. So we have that psychiatrist or the therapist comes with us. So we do an awful lot of visiting people at home for precisely that reason. We learned, we went out to the streets in the first place because people weren't coming to us and they had a hard time coping with that and didn't come. So we've learned if you've got to go see what they're doing in their home to really understand what's going on. And that visit is worth, it's way worth it, even though I'm sure we lose money doing it. But we've learned you can catch people escalating out of control. If you go visit them at home, you can see it and get them started on we have a ton of people on medicine, long-term medicines. And if you go visit them a lot, it's easy to negotiate that. So we've learned, it's just absolutely mandatory. I worry, as we were talking here, that people don't really fund that very much, and often they leave that part out of what is important for support. But I would urge everybody to think that's integral to what you need to do to help some people stay in their housing. And I can give you tons of examples where they lost their housing because they didn't have the opportunity to really get on some treatment or be talking to someone. We could go on. That's a very long story, but you are incredibly correct. I talked to Rhonda about this, that what we need to support people once they get into housing, I think requires all of us to put our heads together and figure out different people will need different things, and how do we make sure that happens and gets funded. And housing is so expensive and so much focus on that. We often think, well, the housing is all they need. And for many people, that is all they need. That's health and health care. But for many people, especially those who've been out for a long time, coming through the COC, they will probably want and need some real support once they get in. And where is that going to come from? And I sat with folks this morning who are doing this amazing work doing that. We don't have anything like that in Boston. We have good medical stuff going in, but we don't have the other supports. Job training, community building, all of those things that we really need help with.
So you had mentioned that initially mental health was not at all involved in kind of the mission that you started. I'm curious to know what the integration of that was like.
It's a great question. So I was shocked by that, but remember, this is back in the 80s. And so, there wasn't that much emphasis. Most people thought you should go to your local community mental health center. That should be it. And so did I, for that matter. So when they said you can't do it here in the shelter, I was like, bummer, but we can live with that. But when I realized, when I went to write a prescription for an antidepressant one night, they said, no, you can't do that. That's mental health care here. Then you start to realize that the line between mental health and other, mental health is just part of care, health care, and it's hard to tease it out. So when we finally integrated it, there was big resistance. So I'll give you just an example. So our psychiatrist, the one I told you about, the one with the red hair, when she was a student, before she went to medical school, founded a place called the Women's Lunch Place, safe haven for women, most spectacular place. It's a drop-in center in a basement of a church down on Newbury Street in Boston that takes women, and it is spectacular. And it's been the guide for us. And Eileen founded that. Then she later goes to medical school, becomes a psychiatrist. And as a psychiatrist, they wouldn't let her back in because they didn't think you should have a psychiatrist on site, because that sort of violates something or other. And it was an interesting, coming together. So we had that precipitated a lot of discussion about how to do it. And when we finally, we sat down with everybody and figured out who has done really well from the streets to getting integrated into care. And it turned out 90% of those people that had done well had an opportunity to get on medication, which is anathema to us. We thought, we don't need medication. But it turned out medication to help somebody get calm and begin to reevaluate stuff is invaluable. That woman that got mad at me got put on medication, which she thought she should have been on years ago, and I didn't give it to her. So I think there's a room to look at this as, there's room for both sides of this, but you have to say for some people, you need medicine and then the support, the right place for them to go. We don't have any, once we get people into the emergency room for, brought in against their will, we don't have many places to send them that are in any way good. We've lost all those beds. So that complicates as well. So I'm now a big proponent of, I think you do need to offer people the opportunity for care if they want. even if they're in their mind thinking maybe I don't, just give them that opportunity. Then we have to make sure we have really good treatment beds on the other side when they want it. And we don't have either one right now on our side. Is that close to what you're, I may be sitting on the fence here, and I'm sorry if it sounds like I'm sitting on the fence.
Hey, Rhonda. Cody Penagagos, Dean of the Dental School, so I'm going to ask you the dental question. What kind of oral health services are you providing to these individuals, knowing that if they're diabetic, heart disease, and the relationship between oral health and overall wellness? And it, already you've got a full plate in what you're providing already, and so just interested to see if you're doing anything.
No, I'm glad you brought that up, because I took out, there's a million slides I didn't show you, because you would be shooting me if I did. But one of the earliest days at Pine Street, Long Island, the shelter I showed you, we had one dental chair and one dentist. And I'll never forget going out there. I was out there every Tuesday and Thursday, most of the afternoon and all night. And he would be there and nobody would go see him. And you had to go down a little hallway to get to where the dentist was. And I started realizing, he's like me, I don't want to go to the dentist. I hate going to the dentist. And so people just don't spontaneously go to the dentist unless they've got terrible pain. And then one night, I'll never forget this, he found one of the ringleaders in the shelter, this really wonderful guy, who had all these fractured teeth along the front. And he looked at him and he said, I can fix those for you. And he took them back and he bonded the teeth so that they looked fabulous. And this guy went out and started raving about the dentist, and there were 210 people on his waiting list the next night. And then we realized we can't handle that. So, but the need for dentistry is huge in this population. And so we have now, we've had a dental clinic, we've expanded. In that main site I showed you, we have, 3 full-time dentists and a full-time oral surgeon. We do crowns, we're actually doing implants pretty soon, which is going to be kind of crazy. But, and it turns out that it's a rotation. We have 3 Harvard and BU dental fellows who come and spend 6 months at a time with us. And in a way you would never imagine, or you would probably know, I just didn't, it's their favorite rotation. And it's not because we're really great, it's because they see things they've never seen before. And they get a chance to really get in on the ground level and see this. So it's a thrive. We have 7 operatories now, but I hear you guys are going to have way more than that. But we've had that, for years. And everybody who comes into our respite program gets a dental screening so they can do whatever they need. But the need is, we're nowhere near hitting the need. But I would say we should never be talking about healthcare of homeless people without including oral, along with the medical, mental health, and substance use disorder care.
Do you do anything with the Boston dental schools with the students themselves? Because I think it's really important to expose students while they're going through their training to this population. I know the fellows are probably, they've already graduated, I'm assuming, and they're licensed and they're coming over, but it would be great to expose students, and you have 3 dental schools in Boston, so.
Yeah, no, and I should have said that. So the fellows actually supervise a whole bunch of students who come in. But the nice thing for us is the fellows we don't have to supervise them in any way. So they can go into an operatory and do everything. But no, we actually have students from all over who come, dental students, which is, for us, you probably heard, it's kind of our lifeblood. Nursing students, dental students, medical students, social work students are all just PA and NP students, all of which you're doing here, are all part of I think that's the pipeline we want to be enticing to get a chance to see what this work is all about. Thanks for bringing that up, though. I had pictures, I should have shown them to you.
Thank you. So I'm curious, Doc, I see the transition, a lot of your patients from palliative care to hospice to end of life. Did any of your patients, and I don't know Boston law, but ever get treated with assisted suicide?
That is a great question. And we don't, in Massachusetts right now, let me say this right, we don't have assisted suicide. So we can't do it legally. And here's something that's been fascinating me, and I'd love to hear from you guys, is we've only known maybe 2 people to actively commit suicide in my whole 40 years. What we see an awful lot of is people who are so discouraged they don't care anymore, but they don't actively commit suicide. But if you would talk to them, they're just hoping to die. So it's been a really tricky thing, but we have not, suicide, and I know suicide comes in waves, but we haven't seen it yet. At least not where anyone is telling us or leaving a note. And it may be that people are killing themselves in the middle of the night by overdosing, but we don't really have any hard evidence of that. If you've got any good ideas on that, you should let us know, because we may be missing a huge and important part of what we should be doing.
Over here, thank you so much for being here. I think a lot of us that do work in areas where we want to, and a lot of us here, given mission and vision of PNWU, want to help underserved and underrepresented populations. I'm really curious about sustainability. It sounds like it was very scrappy at the beginning. Obviously, you said people worked for very little. It was very mission-oriented, I'm imagining, but you've grown. You mentioned 90 million and 700. Kind of a two-part question. How did that kind of develop and grow, grant money or funding, whatever it might be, but also challenges that you see going forward to maintain and continue to have this be sustainable, and not just financially, but just overall?
Wow, that is, thank you for the question, by the way. And as you notice, I probably carefully avoided even going near there. But to be honest with you, we started, it's a slightly interesting story. So we started with a grant. Somebody gave us a grant, right? And I remember starting, and we didn't have a finance department. We didn't send any bills. We just went out to do the work. And I guess it's like getting a global payment, right? And it was amazing. So we could go under a bridge, we could go to a shelter, we could go anywhere. We were paid, and we just went out to do that. Now, the rubber hit the road when the grant ended after 4 years. And then we went, oh my God, how do we sustain ourselves now? And as Neighborhood Health would tell you, well, we were grandfathered in by OBRA of 1987 into what they call, we became a federally qualified health center. So overnight, we just, we had to do all the paperwork, but overnight we're a federally qualified health center where we could now bill Medicaid at cost the way federally qualified health centers do. But we didn't have a finance department. We didn't have, billing Medicaid is kind of a federal crazy thing. So we had to learn how to do that with a caveat is that an FQHC doesn't fit the model of care that we had. But it was a way to sustain at least a part of our program that we needed to sustain. And so for all these years now, since 1988 to now, we've been an FQHC, but for the longest time we had this active respite program which didn't fit into an FQHC's thing. All our street work didn't fit into an FQHC model back then. And so we had, all of our hospital work. So we have rounds in the hospital every day. We do care in the hospitals, tending. None of that is FQHC funded. So we ended up with this kind of 1 foot in the FQHC world and 1 foot in, oh my God, how are we going to support this? Which means philanthropy and all these other things. So, when I say our budget now which is about $90 million a year, about 75 or 80% of that comes from Medicare, Medicaid. I shouldn't say Medicare, but it comes from Medicaid. The rest is a portfolio of grants and all that other stuff. And we're able to do that because we get, like most neighborhood health, most community health centers, we get a grant from the federal government that allows you to then do that.
Thank you so much. That's amazing. I'm also interested in just the organization. You went from kind of this team that was and now it seems like it's pretty, I wouldn't say well-oiled, but there's a lot, for someone outside looking, like, wow, like you have this van and then you've got the clinic here, and how did that all kind of grow and develop over the life of your career, I guess? And it seems like more organized chaos, potentially.
Thank you for saying that. That was great. So, obviously it happened slowly with lots of up and downs over years and with fits and starts. But what I would say is I think we had, like most health centers, we had a clear mission, we knew what we were supposed to do. And as long as we kept our eye on that, then it became easier to know what to do. I'll give you a great example. Okay, so the homeless people on our board of directors, along with our other board of directors and us, we were sort of guiding them on this, had to come to grips with what do we mean, who are we? We're a health care for the homeless program. So what is healthcare? And in the early days, nobody talked about food and housing and other stuff as healthcare. Healthcare was the delivery of healthcare. And so we were conceived and grew up in a world where healthcare was two words. In fact, our program is still that. And for the first 10 years, it was AIDS, TB, heart disease, cancer, all those things. That's what we had to figure out how do you take care of that. And then add on severe and persistent mental illness and substance use disorders. How do you care for that? And so we had to keep to that mission. And we had a crisis one time, I remember about, I would guess maybe 20 years in, about should we get into housing, which is really what I've seen some amazing examples of here, right? And we realized we live in a world with lots of people who do the housing. Nobody else does the health care, per se, as their mission. So we had to put up the white flag and say, we don't do housing. We will work with everybody doing housing to try to do health for housing. So when somebody comes into our program, one of the hardest things for us to talk about, and I would urge you to think about this, is our mission is not to end homelessness. We're doctors and nurses. We can't do it. But we can take really good care of people who are experienced or have experienced homelessness while the societal forces work on solving this bigger than we are problem. And that's very hard if you're young and, it would have been hard for me if I were just starting now because you really want to fix this damn thing. When in fact, our leading cause of, what our leading cause of death is? Did I tell you this? Leading cause of death of homeless people in Boston is cancer. Cancer. It's not, mental health or substance use, although drug overdoses are now coming up to right about the same. But cancer, heart disease, so 1 in 4 deaths is now due to drug overdose, but 3 in 4 are due to heart disease, lung disease, cancer, and liver disease. And that requires a ton of good medical care, which I think we often forget to put into the mix when we're talking about how we're going to take care of people. So we feel like we're archaic. We're a healthcare with 2 words program trying to work in a system. Does that make sense? And I think all of us have to pay attention to the fact that there's 2 issues going on. One is how do we end this problem? It's a societal disgrace. And we're going to end it by we'll never end it unless we have enough housing. Can't do it without enough housing. But for much of that, you're also going to need enough permanent supportive housing. That you need. You got to build that. But in the meantime, there's almost 1 million homeless people in any given night in the U.S. Who takes care of them? That's not ending homelessness. So you can end their homelessness, but the next people who didn't get the early education they needed or didn't get the foster care they're coming out and being homeless next. And we could maybe build our way out of that, but it's going to take us trillions of dollars to get through that housing thing. So I would urge you we got to fight like hell for both, but don't neglect one, don't concentrate on one and say we don't need the other. That would be my appeal to you guys. Don't let somebody die out there because we've got to get housing and they're going to die tomorrow. You got to take care of them. And then forgive each other. That's our job and your job is to do work like that. How about that for being a whiner right now? So, but I think that's important for us to keep in mind.
Thanks. So you answered the first part of my question clearly, that your mission was not to end homelessness, just to bring medical care and good treatment to the homeless population. But have you been able to demonstrate that by having medical services at the Pine Street homeless shelter, that they had greater success in placing people into housing?
No. But I say that, only because to demonstrate that, I have another crusade. Am I allowed to say this, by the way? So my wife, Jill, is a physician assistant. She worked on the streets for years. In fact, Barbara McGinnis, the nurse I showed you about, introduced me to Jill back in the shelter in the 1990s. And she became a physician assistant. And then after many years of clinical, decided to go to get her degree at the School of Public Health at Harvard. And so she did her MPH and then stayed on to do her doctorate. And when she was finished, which is only about 10 years ago now, she wanted to stay on at the School of Public Health at Harvard and study homelessness. That's what had been her thesis, had been on homeless. She did deaths among the homeless people on the streets. That was her big PhD thesis. And do you know how many faculty members at Harvard School of Public Health are studying homelessness or looking into homelessness. And I ask that with kind of tongue in cheek, because, I would argue homelessness is one of the major public health crises facing our country. And how many? It's zero. Absolutely zero. And so I get annoyed when people tell me, oh, homelessness has been a study to death, we know what to do. Truth is, we've all got these small studies. We've done small studies, everybody done. And when you step back and look at them, they're very helpful, but they're not evidence the way we want evidence. And I know the evidence would be there if we just do it right. Then we can convince some people what's going on. But we don't do it. At Boston University School of Public Health, zero. At Tufts University School of Public Health, zero. So, and the reason is not because people don't want to, but there's no federal funding. You can't be supported, right? So you can't get an NIH grant on homelessness. You can't get a CDC grant on homelessness. You can do like cancer and homelessness or smoking and homelessness, but you can't look at the problem you just brought up. And then we have the second problem of, we have clinics, so 14 hours a day, 7 days a week, we have a clinic with doctors, nurses that are in the shelter in Pine Street. We've been seeing people like that for 40 years. The problem is we don't have a before that we can look at to measure the after. So what I think is probably less, I hope we're helping with housing, but the place we're saving a ton of money is people going to the hospital. We see them in the clinic rather than down in the emergency room. But we've never been able to demonstrate that with like the kind of study that people would buy into. And I think that's just a fault of so many of us early on, not thinking about the evaluation being as important as the work you're doing. That's what I would say, that's your job. Find some programs and really evaluate them so we can learn from each other what works and what doesn't.
Hi, I'm Amelia. I'm a provider at Neighborhood Health. This is more of a logistics question. We struggle with our homeless population documenting their different, they have touch points with different parts of our system, but we might not know about all of those, or they lose their meds, or they need to get in for imaging and that doesn't happen and it has to get reordered. How does your program try to manage all of that? Do you have EHR out on like an iPad out on the street? Like what kind of technology have you brought in to kind of help coordinate that care?
Boy, I think this is part of the reason we don't have good studies is because we haven't learned how to do good data, right? No, we have, so from a clinical perspective, back in, I remember 1992, I remember we were doing clinics in about 15 different shelters. We had doctors and nurses doing that. It was all paper, and I could see somebody at Pine Street Inn on a Friday night who might have been seen by one of our doctors at St. Francis House in the day shelter 2 days ago. I have no idea what happened. I just have the paperwork from Pine Street. So we realized back then we needed some way to coordinate this. So Mass General, believe it or not, has a laboratory of computer science, and they helped us create a electronic medical record. It was a clinical record, though, not a billing record, which I've learned is a big difference. And we got so that we could have everybody in our system, anyone seen in any of our, at that time, turned out to be, by that time, it was about 50 different clinics. They were all on the same EMR, which connected to the hospitals. So if they were in the hospitals, we would know it. If the hospitals would know if we were seeing them out there. So it was like a miracle. And since we weren't billing on this, we were just writing, it was all problem-based. Our doctors and our nurses and our nurse practitioners loved it. So everything, wherever you were, except on the street, you bring up a good point, because we had to be connected to a phone. You had to, it was all the rudimentary stuff back then. But it taught us the miracle of if somebody was due for something, you could put a note in there, and if the next person to see them will say, oops, they're due for their colonoscopy tomorrow, we can work on that. So you could communicate, avoid duplication, really fine-tune the medications in a way that made sense. And then all hell broke loose, because then the hospitals started. This was before the hospitals had electronic records. Then they got them, and they all had a different one. Now they're all on Epic. So we have been through, Epic is now our third iteration of an EMR. So we're on Epic along with all of our hospitals and all of our sites. And we still have the problem of how do you get the notes into Epic when you're out on the street. And you can use Epic, there's on your phone you can have a haiku for us. It's called, I don't know if you guys use that too, but so you can do that. But if you're out on the street seeing 40 people on a van at nighttime, you can't get the notes are really tough. So we're still struggling with that. We put That when we see somebody with a major medical issue, we put the note in the next morning. But most of the people we see out there, we're not really getting in the information that I would love to get in there. And it's still a huge challenge. We're wondering whether, because we started to experiment with this, whether AI is going to be the way to go. Because we've learned that you can talk to AI and dictate a note right there and it's ready. The next thing, and you can train AI to do the notes you want. So you can be out on the van and just say, here's what I'm saying, and then the note is done. So we'll see. But if you've got good ideas, people are crying to figure out how to do that.
I will say I spent a year working in Malawi, and each patient had a little booklet. It was like the size of a passport, and they carried it everywhere, and it had just the basics of what you needed to know. And I was like, that just worked so well. I don't know if our patients would, keep a handle on it. They'd probably lose it, but that worked. Yeah. That's like the lowest tech version I could think of. What about medications? I find that patients lose them, they get stolen. Do you guys have any sort of system for meds?
No, just to acknowledge that it's a huge problem. And so we don't have any problem getting the meds because we have a pharmacy, and I'm sure we have a 340B pharmacy, or we use the hospital pharmacies. But what we've learned is to do a lot of 1 week supplies of medicines. We never give a month now or 9 months because people lose it all the time. Then it's a lot easier to get to replace it if you've only lost the last 4 days. So but that puts a huge burden on you as well. It's more and more medications. Turns out the pharmacies love it because they get money every time they refill a medication. So if you're thinking of how to win friends, do that. But that's what we do because it's inevitable. People lose everything out there. We did a whole thing on lung cancer screening using phones that we got from people. And by end of 3 months, there were less than 10% of people still had their phone. So it just, the technology's there, but it's really hard to translate it. I keep wondering whether a watch is the way to go, something that doesn't fall loose off. But for those of you interested, it's a wide open world that we really need help with.
Hello. I've never met a homeless person that has never turned down housing. Everybody, when I go out on the street and talk to them, that's one of the things they want. When can I get housing? And I always try to educate the people out there. Here in the state of Washington, we do have a program through the Department of Social and Health Services where they, if they qualify, they can.
I know where you were. I'm looking around. I'm so sorry.
Qualify for ABD, age, blind, and disabled. Mm-hmm. And if they qualify for that service, there's another service that wraps around with it. It's called HEN, Housing Essential Needs, where ultimately it can also pay for rent. And, when I started out as a housing case manager, it's a lot of work to bring them from square one to, just get, from homelessness to housing, because a lot of them, when I've asked them, hey, who is your provider? Oh, the emergency room. I go there for everything, when I have a pain or something. So a lot of them go to the emergency room for, that's their primary. But, I've noticed so much changes when they get housed. They improve. And I currently help assist clients with Social Security, applying for Social Security benefits. But I feel that, I'm glad that there's that service through DSHS. The state of Washington offers that. And if they qualify, they can get at least $450 a month and possibly getting a rental. But a lot of the folks still do need help, and I remember sitting in waiting rooms at DSHS, even at the hospital. I know throughout the years I've had a couple of them run for me, and I'd be sitting there waiting, what happened? But, it's just, I know it takes a lot of patience, and sometimes, as working out there in the field, sometimes, you do your patients, you just want to but I always, all these up and coming case managers that we are hiring, I always give them that advice, don't run away from challenges, because that's going to be your biggest lesson. That was for me growing up, and but getting back to the benefits, that really does, help them, because you should see a change. Even with Social Security, when one of my very first clients that I helped get Social Security for, well, he actually qualified for SSDI, and he told me, Veronica, you know what, I'm starting to feel like a regular person.
Wow.
So that was amazing. But I just thought I'd add that, comment on that.
Yeah. Oh, thank you. By the way, just to comment on what the first thing you said, is that we used to worry that the people, for example, so you have to remember that we don't usually say unsheltered. We call them rough sleepers in Boston because we don't have many encampments and stuff. They're out on the street. And we used to wonder that question of why are they out there? What's going on? And if they're choosing not to go into a shelter, are they going to say no to housing? And it turned out we had the exact same experience you do. We've had one person in my 40 years say no to housing when offered it. So it is absolutely not true that people are going to say no to housing, even though they may say, I'm not going to the hospital, I'm not going here, they almost never say no to housing.
Yeah, could you just say a little bit about your relationship or how the relationship has evolved with law enforcement and this team?
That is a great question. So, we're blessed, and I think this is where it's probably all local, but so since the mayor put us together, we're a city-based program technically, even though we're out of the two hospitals, our mandate is citywide, and the mayor has always been in our court, which is nice. Remember, I think I mentioned that we don't have counties, it's just the mayor and then the state. So from the very beginning, the mayor has been tortured by how do I handle all these calls coming in from citizens. And so I'm going to say back in 1988, he decided at City Hall to have a weekly meeting with us and the first responders, EMS, and neighborhood groups, and you name it, the police. And it would be we have the Boston Police, we have the State Police, we have there's the park rangers who are there. And then there's the Massport Police, the police who watch over the transports. And we all meet once a week to talk about what the mayor helped us demonstrate was if the police are being tortured by calls about people that are out of control, the van, who goes out every night, knows them all, and they would say to the van, can you go talk to them about what we need to do? And it took what was potentially a police effort and made it a kind of an outreach effort. And I think everybody, police particularly, embrace that. So we've had a really nice relationship with them. I think mostly because we save them having to arrest a lot of people, and it's a lot of work. But those relationships, I would say, the first responders are generally police or EMS. So our relationships with those two groups are critical. And if we can show them we can help, if you're running to someone, we can come and help you, or figure out another way to go, it really helps. But I would urge, I don't know what it looks like, I don't know what the dynamics are here, but for us, we have this problem of, like we had a problem with a thing called Mass and Cass. Turns out the Boston police line ends at one side of the street, and then the state police are in charge of the other side of the street in this one area. So the Boston police are trying to say to people, you can't stay here. They walk across the street. And then the state police come and say, you can't stay here, and they walk back to Boston. So they just go, it's like a back and forth, right across the street. It's not like it's a big deal. So we learned that working together is a whole lot more effective.
So we're going to go with one more question if anyone has one, and then if folks have books that they'd like to have signed, if you brought any books, we will let Dr. O'Connell have a few minutes to have that, but we're kind of wearing him out, I think. Here. So does anybody have a final question they'd like to ask?
Just to be intrude, these kind of questions are amazing. I never get these, so thank you.
Okay, over here. Thank you.
Well, first of all, thanks for being here. I'm from closer to where you are from. I'm from Fall River, Mass. And we are now.
I'm sorry, from where?
Fall River, Mass.
Oh my, I'm from Newport. You know that, right?
Okay, I didn't. Okay, great.
We're there.
It's always striking to me that the challenges that are in Fall River, even here in Yakima, seem to be the same challenges. In all the years that you've been doing this, and maybe this is oversimplifying it, but do you think things have gotten better? Do you think the situation is worse? And what gives you hope that, I guess for a Boston analogy, you're doing more than just kind of shoveling snow during a blizzard that doesn't seem to end?
Yeah. You know, a great question that sort of hits deep down, because I would say, if I step back, I remember when we first started in 1985, we thought, and the Robert Johnson Foundation was a 4-year program, thinking this was a temporary emergency, we'll fix it and move on. And I never thought I was going to do this for my life. I thought we were going to get past this. So I would have to then stop back and say, well, the truth is it's way worse now than it was in 1985. So I can't claim that all the work we've done has changed the big picture. So then it calls into question of, so what are we doing? What's going on? And that's when we have to run for cover a little bit, because I think, one, homelessness has become immensely more complicated than ever before. The different groups at different situations, you name it, from families, migrant families, adults and adolescents. We have a big trans or agenda specific care program we started about 20 years ago when we thought it was a tiny little problem. And now we do the full care for probably 100 people who are either thinking of or have transitioned. Never would have dreamed of that. And it's, when you watch what they've lived through, it's unbelievably difficult. And so I don't see that getting better. We actually, one of the board members we have who's homeless is a trans woman, and she's fierce in her advocacy and teaches us what we need to be doing. So when I think of things like that, and then we didn't have a fentanyl, heroin. For those of you who weren't around then, so we had alcohol and heroin and cocaine. Those were the sort of things. And heroin is kind of a mellow drug. So, it's like jazz singers would play great on heroin. So it makes you mellow. And then all of a sudden, you've got fentanyl, which kills you within minutes. And then methamphetamine that makes you feel like you're a super person. And then there's a whole behavioral thing that didn't happen before. So I think all those complications have made it immensely more difficult for us to help out. The other thing I worry about is that the public sentiment toward homelessness, which once, at least in Boston, was once of, let's try to care for these people are our brothers and our neighbors and our sisters. Now it feels like more like these are the criminals, these are the people that are ruining our cities, and what are they doing here? And I worry a lot about how that's going, and that discourages me from thinking we're going to come to an easy or near solution to this. And then the last thing I would say is I really am convinced that if you really look at homelessness and say, what's the root problem here? I think you have to hold, the only easiest way I've said, if you hold a prism up to society and homelessness, what you see refracted is the weaknesses in our school systems, our justice system, the racial issues going on, agriculture, you name it, it goes on. And if I were to say, how are we going to end homelessness, I'd say in addition to having the housing, we're going to have to fix all those weaknesses. And that's a societal commitment. Somebody asked me if I had, a bunch of money, what would I invest in if I could only do one thing? And I know what I would do. I would put it in early education, and I would pay school teachers $100,000 or $200,000 a year. And then 20 years from now, we'll see a lot less homelessness. But that's not the, that's the complexity of it. And there are, I have friends who will do something completely different. Just an example that we need there's no easy solution or no one solution. It's got to be a mosaic, I think, of really creative solutions targeted to the specific needs of the populations we're caring for. Is that okay? I'm sorry. Okay.
Okay, that pretty much concludes our program. So
thank you.
Let's thank Dr. O'Connell for his time.
Thank you.
And thank you all very much for joining us this evening. It's really a privilege to have you here and to have the interest in this very significant problem that we should be dealing with. We're probably going to be following up, I hope you don't mind, with an email getting some reflection from you, some feedback. So you may receive an email from us in hopes that you can give us some perspective and some feedback on what you thought about the presentation and how we can make improvements for the future. So thank you again, and have a safe trip home. Thank you.